Good morning, everyone. Welcome to the Cancer and the Environment Forum. We're thrilled to have all of you here in person, as well as I think 300 people are going to be online today. So we will have a hybrid audience, and we will be taking questions from online as well as in person. So thank you so much for coming today. This is a jointly sponsored seminar on the cancer and the environment from Columbia University, Herbert Irving Comprehensive Cancer Center, and also the Silent Spring Institute. We have partners from all around the city, as well as partners from Silent Spring that'll be speaking today. We have a fabulous program dedicated to showing all of the latest evidence on the environment and cancer. Before we start, I want to do the land acknowledgement. The Lenni Lenape and Wappinger people lived on this land before and during colonization of the Americas. We recognize these indigenous people of Manhattan, their displacement, possession, and continued presence. We are reminded to reflect on our past as we contemplate our way forward and support indigenous people and other marginalized communities of this land and advance our commitment to justice. So with that, again, I'd love to welcome you. My name is Mary Beth Terry. I am the Executive Director of Silent Spring Institute and also the Associate Director of Population Science here at the Comprehensive Cancer Center. We're thrilled that you're joining us, and we're thrilled that we have a dedicated team that has worked on this event over the last few months to make sure that this is a non-industry sponsored event. We have the support of the Community Center, which you'll hear about a little bit later, the SOCA Center, as well as the Stony Brook Cancer Center. So we are very grateful for those sponsors as well. And I'd love to introduce then my colleague who's been part of the organizing committee, Dr. Linda Mermelstein. Dr. Mermelstein is a true physician, public health person. She has dedicated her career to serving public health on Long Island. She literally has taken care of millions of people. She had been with the public health department, serving as commissioner twice. She knows everything there is to know about water on Long Island, so see her at the break if you want to learn more. We are, because we have so many people today that if we describe their bio, it would take the whole day. So we are sharing a bio book so you can learn more about Dr. Mermelstein's amazing work that she has done. And without further ado, help welcome Dr. Mermelstein.
Thanks, everyone. I'm so excited to be present at this program. We're going to be providing you with information and resources that clinicians and health professionals need to be able to help recognize, prevent, and address environmental exposures that can contribute to the cancer burden in your patients. So today we're going to hear from experts on cancer and the environment, and we're fortunate to have Dr. Paolo Buffetta, our Jeffrey Howe Memorial Speaker. Dr. Buffetta is a leader in the field of cancer epidemiology, and he's currently the Associate Director for Population Sciences at Stony Brook Cancer Center. He's a full professor in the Department of Family, Population, and Preventive Medicine in the Renaissance School of Medicine at Stony Brook University. So we're going to be presenting with panels including 14 experts focusing on the medical fields that give care to the most vulnerable population for environmental exposures. And our panelists are going to be providing important information. And then afterwards, we're going to have the opportunity to ask questions. So I ask that you please hold your comments and questions until we open the panel discussions after each speaker. We're addressing environmental, I'm sorry, can you go to the next slide? Do I do this? I do the slide. Sorry, that was the agenda. I'm going to take a look. Okay, so we're addressing environmental exposures, and you might ask, cancer mortality rates have gone down, and with improved treatment and addressing some of the most notable causes of cancer, but cancer incident rates have continued to increase for certain types of cancers. So people in our communities will often ask, well, is it something I ate? Is there something in my drinking water? What's causing all this cancer? In fact, in my own experience as the health commissioner in Suffolk County, Long Island, the public has been asking these questions literally for decades. So you hear about some of these causes today and what's known and what's not known about these exposures. So cancer prevention does work, as this chart, which looks at several of the higher incidence cancers, and it shows us that the cancer incident rates have come down in the last few decades for people who are age 70 and over, which is the yellow line at the top, or the two yellow lines for males and females. This has been attributed to lower smoking rates. But that being said, even though some of the cancer rates are going down, cancer incidence rates are going up in people under age 55, in particular women under age 55, as you can see from the bottom two, the blue and the orange lines. We know that cancer causes are multifactorial. People's cancers are not only dependent on what they inherit from their parents. Between 2011 and 2016, the New York State smoking rate decreased by 22%. But even though smoking, which is a known cause of cancer, has decreased, cancer rates are still on the rise, particularly in younger cohorts, as you saw in the last slide. So the American Association for Cancer Research, they prepared and published a cancer disparities report in 2024. And this is a slide from their report. And it shows the multifactorial drivers of health. And these impact disparities in the cancer continuum all the way from development through survivorship. And environmental exposures, which is the big red arrow, or that shows they have involve structural and societal factors that impact cancer. And these are systems issues, and people or individuals cannot make changes or headway in modifying those factors. The AACR report also lists the modifiable cancer risks for which the individuals can actually change behavior and can reduce their own risk of cancer. And it's really of public health benefit to make sure and communicate these factors to patients and to give them the chance to prevent cancer for themselves. But you'll notice here that environmental exposures are not listed. And while individuals can take actions to modify their own behavior, many environmental exposures are beyond their control. And so they result again from societal factors. Often policymakers are given this list and it doesn't have anything about environment. So they miss that messaging that it's really important to make system changes to address and reduce environmental exposures for the population. And these exposures are harder to measure, and often people have multiple types of exposures. Still, things like tobacco smoking, excess body weight, alcohol, UV radiation, poor diet, infection, and physical inactivity can impact cancer risk. Modification of these factors can reduce cancer for individuals, and development of educational programs and policies can further reduce the risk for the public. Above and beyond what's written, environmental pollutants, occupational exposures, and reproductive factors are among the causes of the cancer burden that we're experiencing, and health professionals really need to be aware of that and to address these issues as well. So these are the major environmental exposures that will increase risk for cancer. Some of these exposures are compounds that have traditional, the higher the dose, the higher the risk. But some low exposures can be just as harmful as the higher dose exposures. And everyone is exposed even at low levels, and therefore the population is at risk. So we get exposed to many chemicals at once, and we can get exposed over time. So these exposure may also happen through multiple pathways, breathing, drinking, and food. So household products and personal items can also be a source of exposure, and higher exposures may take place depending on one's occupation, their geographic location, and other factors. For example, your proximity to an unexpected incident, if there's smoke or fires or chemical spills near where you are. Each of these are major risk factors, but we're not exposed in isolation. So for example, smoking Smoking-related exposures magnify the impact of other environmental exposures. Environmental health research shows that exposures of mixtures of chemicals can have joint effects, interactions, and multiplicative effects. In addition to the items that cause harm, there are also categories of people where there's more vulnerability to the exposures. And as health professionals, it's important to know what the potential risks are in your geographic area and what characteristics your patients have that might make them more vulnerable. With this knowledge, you can take the necessary steps to educate your patients, counsel them on prevention, and order the needed screenings to reduce their cancer burden. So our panels today are going to work to describe the common environmental exposures that are experienced by patients in the medical field. They're also going to describe current evidence and knowledge gaps on these exposures and their impact. And they're going to provide evidence-based risk reduction strategies through education and counseling for your patients. Additionally, we will provide helpful resources and ways that you as a healthcare professional can advocate for systems and policy changes to reduce the environmental cancer burden for the population. So we welcome you all and thank you for attending today's conference.
Thank you so much. And without further ado, we'll start then with our first panel. And our first panel will be moderated by Dr. Sarah Evans. Dr. Sarah Evans, again, we'll keep the bio short. So the one thing I'll tell you about her is that she, in addition to producing amazing research, so look some of that up, volunteers her time to be part of the New York State Environmental Working Group. We're not an advocacy organization, but we're an education organization, and we teach policymakers about the evidence of environmental chemicals and health. So thank you, Dr. Evans, for volunteering your time to do all of that work, important work, as well as your own research.
Thank you so much, Mary Beth, and thanks everyone for being here, and really the honor is mine to be part of this amazing group. So I'm really excited to have the opportunity to moderate the first panel. This is on environmental risk factors for cancer in obstetrics and gynecology and pediatrics. And so this morning's panelists will discuss what we know about the links between environmental exposures that occur specifically during the prenatal period and early childhood and risk for childhood cancers and also cancers that develop later in life. And importantly, they'll share best practices that health professionals can take back to their patients and communities to share what can often be really complicated and sensitive information in a way that's understandable and, importantly, actionable. And I think before we start, it's worth noting that pediatric health professionals have really been at the forefront of integrating environmental health into clinical care, recognizing decades ago that lead was a harmful exposure to children when experienced early in life. And the panel is going to go in depth, I think, into why we're so concerned about exposures that occur during these really sensitive developmental periods. Pediatricians are also, and OBGYNs are really trusted sources of information for families for guidance on how to keep their children safe and healthy. But while we know a lot about how to keep families safe from lead, so we can measure lead in the blood, we can identify sources, and we can even remove some lead from the body when exposures are very high, it's much more challenging to help patients navigate some of the exposures that Dr. Mermelstein mentioned earlier, things like PFAS, microplastics, hormone-disrupting chemicals, which you'll hear more about from this panel, all of which are really prevalent in our homes and environments and have been linked to risk of cancer. We find that these chemicals are also really prevalent in headlines, and so you'll hear a little bit about how we help families navigate through some of this really scary information, and also counteract, the spread of misinformation that's really kind of rampant through social media now. And so when individuals understand what it means to be exposed to chemicals and contaminants in their environment, and they have proactive actions that they can take, it can be empowering. And I think sometimes as clinicians and scientists, we're afraid to share information when there's uncertainty. And so we're hopeful that these panels will help you kind of navigate how we communicate with patients sometimes in the face of uncertainty. So I'm a research scientist, and so I really understand the challenges of conveying this complex information when science is still evolving, but I'm also a parent, and so I've been on the other side of things, and I recognize those fears and uncertainties that patients often come. And so today on this panel, you're going to hear from Doctors McDonald and Kahn, who are going to lay the foundation for the current state of the science and what we know about early life origins for later life cancers, and what makes the developing reproductive system particularly vulnerable to disruption by environmental chemicals. And then we'll hear from Drs. Thompson and Dr. DeBolt, who will describe how they're utilizing screening and educational tools in pediatric and obstetrics practices to help families reduce harmful environmental exposures. I think without further ado, I'm going to invite our first speaker up. Each panelist will have about 5 to 7 minutes, and then we will open it for questions. And so for those of you who are online, you can use the Q&A, and we'll try to get to as many questions as we can after the speakers finish. So I will now introduce Dr. Jasmine McDonald, who is an assistant professor here, associate professor? Associate professor here at Columbia. Thank you.
Well, thank you so much. It's a pleasure to be here, and it's a pleasure to see all of you here as well as online. I just wanted to kind of like open up our panel and talk about what is cancer in the environment. And one thing I want us to all remember is that time and biology are intertwined when we're thinking about cancer in the environment. Cancer has a very long latency period, and this will not change, just to let you know, just me. No slides. Cancer has a very long latency period, and one must live long enough to develop cancer. This is in part due to the reduced efficacy of our DNA repair system over time. So, if you think of your DNA like a car, if anyone knows me, I'm an analogy queen. But if you think of your DNA like a car, your body is a very busy car manufacturer. You're constantly replicating the exact same model. This is the model that works for you and is for you. But every now and then, you may manufacture a wonky car. Maybe it has 5 wheels, or maybe it has no steering wheel. But you don't really worry about that because you have the most effective pit crew throughout your system. This is your DNA repair system, and it is pretty infallible. It's very, very good. However, if you think about this over time, you must have an effective pit crew because if you start reproducing DNA that isn't correct, things go awry. So think about your pit crew. It's constantly throughout your body creating, correcting, repairing any wonky cars. Now imagine what happens during sensitive windows of growth and development. These are period of time where we consider like the prenatal, the pubertal, and the postpartum windows. These are times when your body is rapidly replicating cells. Therefore, you are rapidly going through DNA replication. Now, during these times, you need an infallible pit crew. But the effective pit crew you had at age 5 is not as effective at age 20, 30, 40, and so on. Over time, they can't inspect, patch, or tune every single car without error. They become infallible. So therefore, you may begin to manufacture 5-wheeled cars. Now, if you think about this during the critical windows when you have high proliferation of your cells, therefore you have high DNA replication, this is of particular concern, especially if you have environmental exposures that are occurring at the same time. So we see this biology borne out in the data. I'm especially interested in this analogy in the context of when women are diagnosed with breast cancer within 5 to 10 years of childbirth. We refer to this breast cancer as postpartum breast cancer. Now, we are seeing a rise in early onset cancers in general, and breast cancer is no exception. But if you look specifically at the increase in early onset breast cancer, many have suggested that it's genetic or the changes in reproductive factors. But that's not the primary case. It's definitely not the case for genetics. germline genetic mutations take a much longer time to manifest population wide. And while we have high penetrance mutations, such as BRCA1, BRCA2, PALB2, which increases your individual risk, no gene is deterministic for cancer. So while this increases individual risk, is not a guarantee, and this only represents about 5 to 10% of all cancers. Moreover, studies done by Lima, Kim, and Terry have looked at the changes in reproductive factors in alignment with what we see in early onset breast cancer, which is typically those being diagnosed at age 45 or younger. And what they have shown nationally and globally is that later age at childbirth and changes in parity, which is having fewer children, those trends are not the primary cause that we're seeing for early onset breast cancer. So, what is it? Well, there must be something environmental that's interacting with our genes that's driving this cancer initiation, promotion, and or progression. And analogous to potholes and speed bumps and stop and go traffic, let's get real. We are constantly exposed to air pollution, pesticides, endocrine disruptor chemicals, microplastics, and even dietary patterns such as high intake of ultra processed foods have been shown as an emerging for cancer risk. So, cancer and the environment go hand in hand. Those chemical exposures experienced in early life, even after the chemical has been excreted and you're no longer in direct exposure, can still have effects in later life. This is why, our clinicians, especially those at the gateway of prenatal, early life, and postpartum care, have such an important opportunity. By applying principles of risk communication, you can effectively inform patients and families, because this is a multi generational effect that we're looking at, about reducing potentially harmful exposures. Now, how I see it is that these are moments of direct individual or patient level care, but it's also moments of prevention. And they remind us that addressing environmental risk is not only good medicine, it's good public health. So, of course, understanding these windows of susceptibility, which I kind of grazed over, requires following individuals over time from the earliest stages of development. So, what I want to do is just hand it over to Dr. Linda Kahn. She's done remarkable work in this area, and she'll take us deeper into how early life environmental exposures using the Doe hat theory shape long term health outcomes.
Thank you so much, Jasmine, for that terrific lead-in. I am here to talk with you today about what we mean about the developmental origins of health and disease hypothesis and how endocrine disrupting chemicals can affect fetal programming in a way that may predispose people to cancer later in life. I have conflicts to declare. So, when we talk about fetal programming, we're really referring to a hypothesis, which is colloquially known as the Barker hypothesis, which was put forth by David Barker, a British epidemiologist, in the 1980s. And what he noticed was when he did an ecological study looking at rates of infant mortality in counties in England which had in the 1930s, they were highly correlated with rates of cardiovascular disease 50 years later. And what did he take away from that? Well, he surmised that these high rates of infant mortality, which this was the 1930s, it was a depression. These pregnant women had been nutritionally deprived, and their infants had not thrived. And so the infants that did survive, however, had some kind of
wiring that had occurred during prenatal life when they were deprived of adequate nutrition that put them at risk for cardiovascular disease decades later. And this led to this theory that exposure, in his case to inadequate nutrition, but one could also say to other exposures like environmental chemicals, during prenatal life might have long-term effects on human health. And since then, in the decades that have ensued, a lot of experimental and epidemiologic research has shown that there indeed is evidence that various biological pathways, such as epigenetic alterations, effects on fetal immune system development, and alterations in fetal hormone development may be the cause of this permanent effect on human health. And when we talk about a critical or sensitive period, what do we mean? We mean a very particular defined time period in which an exposure has an irreparable effect. So this is in the context of fetal development, which is very highly choreographed, right? Different organ systems are developing at precise times over the course of those 9 months. Think an environmental exposure at a particular moment can have an irreparable effect on whatever system is developing, like thalidomide. This is the perfect example of what we mean by reproductive programming. It's inalterable. So one of the critical periods in fetal development that I want to focus on is sexual it's the moment at which the fetus becomes either male or female. So up until 7 weeks of gestation, the physiology of the fetus is there's only one. There's only one type of fetus, and it's wired to become either male or female because it has both Mullerian ducts and Wolffian ducts. And it's at 7 weeks gestation when, in the presence of hormonal signaling, it will make that choice. So if there is no exposure to certain hormones, the Wolffian ducts will just disappear on their own. They'll be resorbed. And the Mullerian ducts will develop into female reproductive organs. So that's why we say the default sex will be female. However, in the presence of Sertoli and Leydig cells, which have developed at this point, and these are the cells that in an adult populate the human testis, they release AMH, anti-Mullerian hormone. Many of us think of this in the context of female fertility. Actually, it's called anti-Mullerian hormone because of this moment in development when it is produced by Sertoli cells, male cells, and causes the Mullerian ducts to regress. At the same time, the Leydig cells, which throughout the entire male life course produce testosterone, release testosterone that fortify these Wolffian ducts so they don't regress. And in that case, they will develop into the male reproductive organs. So what happens when you expose a fetus to endocrine disrupting chemicals at this critical period? Well, we can do that in animals, and animal studies have shown that when you expose rat dams to phthalates are a class of endocrine disrupting chemicals that are found in plastics, personal care products. We've all got phthalates circulating in our bodies at this very moment. In the medical context, they're in your IV bags or in your medical tubing. That this interferes with Leydig and Sertoli cell differentiation and function, meaning that you have lower hormone levels released at this critical period. And then when the pups are born, you can sacrifice the male pups and you can weigh their teeny weeny little reproductive organs. And you find that those that were exposed to phthalates have lighter organs, meaning that they didn't develop as robustly. And then you can also measure something called anogenital distance, which is the distance between the anus and the either the penis or the vagina, the vulva. And it will be shorter in male pups who were exposed to these anti-androgenic chemicals in utero. And this is a measure that tracks throughout life. So even in an adult or an adult rat, you can see shorter anogenital distance in those who've been exposed to prenatal phthalates. So a bunch of different epidemiologists have since noted that there is a cluster of developmental abnormalities that are associated with prenatal exposure to
endocrine disrupting chemicals. And Neil Sakebak, who is a Danish epidemiologist, coined something called the testicular dysgenesis syndrome. And he found that among many other outcomes that you can predict, testicular cancer rates are associated with prenatal exposure to these endocrine disrupting chemicals, as well as cryptorchidism and hypospadias. Other ecological evidence that supports the association of environmental chemical exposure with male reproductive health are the increase in plastic productions, which are inversely correlated with sperm count globally. Similarly, hypospadias rates have increased over the same time period, as have rates of testicular germ cell cancer. There is a parallel theory of ovarian dysgenesis syndrome. We don't see these effects immediately upon birth, so it's a little harder to track this in epidemiologic studies. But you can see that the suite of outcomes that are predicted to result from prenatal exposure to endocrine disrupting chemicals in the females are the same reproductive site cancers that you would expect, and as well as other gynecological disorders such as fibroids, PCOS, and endometriosis. So, just to summarize, what we know is that across both animal and human studies, prenatal exposure to a number of environmental chemicals is associated with reproductive site cancers. The evidence is strongest, particularly in females, for the persistent chemicals, because we can look at levels of these chemicals in the mothers of women who have reached the age of reproductive cancers, and at that point, their mothers were exposed in a generation when these chemicals like DDT, which Rachel Carson campaigned against, were more prevalent. And we can see now that the non-persistent chemicals as well are showing similar effects. I want to thank you, and hand it off to my clinician colleagues here because I know nothing about what they do.
Hi, everyone. I'm Chelsea DeBolt. I'm a maternal fetal medicine physician at Mount Sinai and an OBGYN.
And I'm Dr. Hannah Thompson. I'm an environmental medicine physician from Mount Sinai.
And we're going to talk a little bit about the implementation of environmental health into perinatal care. As an OBGYN, I always say that I have a prime audience of a pregnant mom who cares much more for her baby sometimes than for herself. But because of that, I have the prime opportunity to discuss the types of exposures that she may have experienced and may experience during a pregnancy, and what those exposures may mean for both herself and her fetus. A lot of the time, our patients may or may not have even had care themselves for years prior to this. And so again, the perinatal time period is really an opportune time for us as clinicians to have a captive audience. And so it's really important for us to sort of jump all over that opportunity. So it's been mentioned multiple times about windows of susceptibility from our prior two talks. And for females specifically, there are windows of susceptibility to both environmental health exposures and how those health exposures can lead to detrimental effects such as cancer. This is because women, of course, have susceptible hormonal tissue, which we know can change over multiple time periods during a woman's lifespan. And it's important to understand that new exposures are important, but also cumulative exposures also alter risk. And this is something that, again, can occur over the lifespan of women. As has been previously mentioned, the time during in utero and early in childhood, we know there's rapid development, rapid growth of cells. And so those time periods tend to be most susceptible to environmental exposures that lead to detrimental effects. Other times that we think about in the perinatal period, not just for pregnant women who again have hormonal tissue that is susceptible, we think about the placenta, which leads to the susceptibility for the fetus, of also environmental health exposures that can lead to an array of disruptors that potentially are later on in life, not just during childhood, but adult life as well. And then, of course, we think about the menopausal transition. So for later in life or midlife women, we also think of this time as a very hormonal susceptible time that I think sometimes actually often gets overlooked in a woman's life, and also through women's healthcare is often overlooked as well. which is unfortunate because there is so much susceptibility during that time. There are hormonal changes that occur, changes to the immune system, and significant metabolic reprogramming that lead to long-term detrimental effects for women. It can lead to chronic health conditions, but as well lead to that environmental effect that can lead to cancer. And because this happens later on in the woman's life, this is really a time where we think about those cumulative effects that have happened over time. So as clinicians, we always think like, what can we do? How can we help? How can we ask these questions? And how can we elicit information to give people the education that's necessary for them to understand what this means? So one way is to utilize the American College of Obstetrics and Gynecology. ACOG has a few great clinical guidelines available for OBGYNs and other clinicians to utilize in their practice. I'm not going to go through this specifically. I just wanted to show you an example so that you can better understand the types of things that we should be asking about during an OBGYN visit, whether that's a prenatal visit or not. And so some of the elements that they discuss here are, of course, the key elements of the environmental history, the agent itself, any reported associations. This is specific, of course, to reproductive outcomes, and then how you could potentially counsel patients about how to minimize these exposures, and also gives more resources to point to for clinicians to point patients to as well. They look specifically at lead, which is a large part of especially the prenatal period and neonatal period in childhood as well. They look at the home environment and lifestyle. They go through cleaning products, personal products, and things that you should be asking your patients about. They also, of course, look to diet and nutrition and seafood consumption. Fish, that's a large one. There's a dedicated table to this in this document specifically, but of course we have pregnant patients coming to us all the time asking what they can or cannot eat, what they should and should not avoid. And then of course diet nutrition goes beyond just seafood and fish, and those are listed here. And then importantly, they also look to the workplace and any occupational exposure for patients to ask the specific questions that you need. There's a lot of resources. Both ACOG and the Society for Maternal Fetal Medicine do have up-to-date statements available through their websites, which clinicians should utilize to help guide them when speaking to patients. Specifically, the Reducing Prenatal Exposure to Toxic Environmental Agents Committee opinion is very helpful, especially for an initial prenatal visit or prenatal care. And then they also have the lead exposure as well. I don't know if it's on that, but they also look to timely exposures as well. So SMFM during the wildfires did put out an alert in ways in which clinicians could speak to their pregnant patients during this time period. So they also do try their best to look at time-sensitive events that are happening to try to give guidance. And so our hope is we're sort of pointing you to resources that you can utilize as a clinician to help educate your patients and then to give more resources to your patients. As we all understand, time is of the essence when you're doing these visits. And so it can be extensive to do a full environmental health history, but it's important to at least think about this and find ways in which you can incorporate this into your clinic practice. Then I'll let you talk about the PACU, which we often also will point our patients to as well.
Hello. So I am an occupational environmental medicine physician, and one of my key roles is I work with the Pediatric Environmental Health Specialty Unit at Mount Sinai. And this is a group of really dedicated healthcare professionals focused on children's environmental health and really educating healthcare professionals around environmental exposures that impact children. And so one of my roles on the PACU is what we lovingly call it, is to work on a special project focused on childhood cancer and the environment. And so in this special project, we particularly are focused on educating healthcare professionals around the what we know about environmental exposures and childhood cancer. And so, as Dr. DeBolt mentioned, I just wanted to highlight a few of those specific resources that we have available for clinicians who may have patients come into their clinics in the perinatal period or even after the child's born and have questions around environmental exposures and connection with childhood cancer. Um, so in general, the PSU has a lot of resources around um, childhood period and environmental exposures. And so the link is up there. Our resources vary from air pollution to heavy metals in baby foods. And really, as Dr. DeBolt mentioned, it's really focused on key messaging in very simple terms that everybody can understand, along with really ways that they can mitigate exposures and decrease risk. And so this is another one that I work with. So in New York State, we are really lucky to have the New York State Children's Environmental Health Centers. So these are like PACEUs, but the PACEUs are located all over the country, but this is just specifically resource centers across New York State. And they all work together to really inform New York State communities and healthcare professionals around environmental exposures in children. And so I think one of the most dynamic resources that they have available is they have prescriptions for prevention. And so it's kind of based on like an old school prescription pad where physicians would write down their recommendations. These are, again, really simple key messaging that you can talk to patients about. So this example is on air pollution and outdoor air quality. And so as you can see, it's just very simple messaging action plan for patients to, avoid outdoor activities when there's, high levels of pollution, as well as resources. So for example, checking airnow.gov, which provides the AQI or kind of like a scale of what the outdoor air looks like at the time. And then this is another one focused more on the perinatal, but in resource, honestly, that's a little new to me, and I've been really enjoying looking through it. But it's called Mother to Baby, and they also have, as Dr. DeBolt mentioned, like really simple fact sheets related to things like methylmercury in fish, and so it could be another good resource for your patients if they have questions specifically for kind of the perinatal period. And lastly, as I mentioned, so this is our specific childhood cancer in the environment, and we have a lot of amazing resources really geared towards pediatric oncology healthcare professionals related to what we know, like kind of the most up to date environmental epidemiology related to childhood cancer. And so this is our QR code for our newsletter, so you can stay up to date on our activities. We have webinars a few times a year, as well as we're always welcome to and excited to talk to people on this topic because it's something that is really near and dear to our heart. Because as we kind of already talked about, along with other types of cancer, childhood cancer incidence is rising too, and so there's a question there that there's likely some environmental drivers. And so finally, I just wanted to talk briefly about taking environmental health history because I think all of these resources are amazing, but we can't use them with our patients unless we ask about environmental exposures. And so this is actually my diagram of like how I've tried to conceptualize what the environment is related to medicine. So environmental health is just this humongous field that takes into account epidemiology and public health, but we're really in this small little box here of environmental medicine where we really try to connect the population epidemiology with the patient sitting in front of us. And so what their exposures are, what their symptoms are, and how they may or may not relate to the environment. And so it's something that we don't learn as much about in medical school, but I think it's really, really important and can have impact points across patients' life course. So taking an environmental health history, I think, can be challenging sometimes for clinicians because of time constraints and just clinic obligations. But really, environmental health history is an important part as any other part of the history. So it can be used to identify and diagnose, to treat, as well as prevent environmental health conditions. And as Dr. DeBolt mentioned, it might just be a simple question. So somebody might have a symptom that you think maybe is related to lead, and so you might want to ask a lead question. Or we could also use it for screening. So, if perinatal patients come in, we might want to ask everybody about lead to screen the general population. So it can be really tailored to the clinic and doesn't need to be an extensive history like I would do in my environmental and occupational clinic, but it can be really targeted to your patient's needs and your patient's symptoms. And it can be also updated frequently. So you may have a kiddo come into your pediatric clinic who is 1 and 2 and have mouthing behavior. So lead may be a concern versus when they get to be 10, 12, they may have other concerns and other environmental exposures that may be at play. So it can really be changed dynamically to meet the patient's needs. And so this is just an example of kind of a outline or a mnemonic for taking an environmental health history. Like I said, it can be picked and choose depending on the patient's needs. I will say for a pediatric audience, I think I really envision the environment is where we live, we sleep, we work, we eat. So where I would say community, we should add school if you're talking to a pediatric patient, because a lot of exposures can happen in the school environment where kids spend a lot of time. And then I will say also occupation, don't underplay that in the pediatric population because parents can bring home exposures to their kids. And so that's an important piece, even if you're talking to pediatrics patients. And then I think for clinicians, just thinking about environmental exposures really within the social determinants of health can be a nice place to put these questions when talking to patients. So this is our emails. We would love to talk to anybody who's interested further, but thank you so much.
Okay, thank you so much for sharing all that really excellent information. I'm going to open it up now for questions, but before I do, I wanted to take advantage of the fact that we have this really dynamic panel here with diverse backgrounds in both conducting really elegant scientific research and also seeing patients in the clinic. And so what I wanted to ask for Dr. McDonald and Dr. Hahn, where do you see your role as scientists in engaging with health professionals to try to translate your research to improve the health of populations and patients? And then for the clinicians on the panel, Dr. Thompson and Dr. DeBolt, what do you need from scientists? So, how can we, sort of better bridge communication across the research setting and the clinical setting to make sure that our research is really actionable for patients? So I don't know if you want to start, Dr. McDonald, do you mind? I think you have a microphone.
Hello, there we go. In my world, I come from like bench science, basic science. I worked with mice and in vitro studies, and I realized that the translation of that work would take a lot longer to have a clinical impact. So when I switched to a population sciences standpoint, my goal was to take the biological underpinnings that I grew to understand and love and appreciate, but bring that into epidemiological studies to make the study designs for the epi studies more grounded in the sciences so that clinicians not only have the epidemiologic evidence that they need, but they have the biological signaling processes that are related to those conditions. And so that's how I kind of feel that my need is. And then the second part is that there are areas that are underrepresented. There are people who are underrepresented. There are communities that don't really have the same culture as what we see that's in our textbooks. And so I also try to engage these communities to understand what they're facing and including them into the research process. And then lastly, it's about making sure that whatever I do is able to get to the clinicians. Oftentimes we just like write it in a book and then or put it in a paper and that's all there is. But when you're able to collaborate with organizations like Silent Spring Institute or other organizations that are environmentally like talking to the public, you have a better way of making your science digestible and actionable.
I would just echo everything that Jasmine just said. My background also is in bench science, and then I took a long detour and came back to population science. And I do feel that translating our research across disciplines is one of the most important things we can do. I actually spent that intervening 20 years as a book editor. So a lot of what I do is writing. And I think it's very important to translate our scientific findings into language that the public can understand. When we write, we should be more engaged with public media, writing editorials, writing articles for the lay press, or allowing ourselves to be interviewed about our science by the lay press and trying to communicate to people beyond our little ivory tower. And the other audience that I think is very important, besides the public and clinicians to communicate our results to, are policymakers. This is essential because, as Dr. Mermelstein said, environmental chemicals, we can advise our patients and our children and our friends, okay, don't microwave in plastic and don't use your Teflon coated pans, blah, 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 blah. However, most of this is outside our control. I mean, that is nibbling around the edges. The main sources are things that we have no control over: the food system itself, water quality, air quality. For this, we have to go up a level. We have to go to the policymakers. We have to advocate for regulation of these chemicals at the local level, the national level, and the international level. As some of you may know, there's a treaty that's being negotiated, has been in process of being negotiated for many years now at the UN level to regulate plastic production. So these are the kinds of people we also need to be speaking to and presenting our science to have an effect on the population's health.
I think from our standpoint, one thing that I find very important as a clinician is to be in the room when the science is being discussed, to be in the room at the sort of conception of research projects and questions, because I think clinicians are at the forefront, of course, of questions that patients are asking, and ways in which we have to convey the information to patients can sometimes be difficult. And so if the clinician is in the room from the beginning, I think that makes it much easier to sort of conceive and bring up a project that is really going to be meaningful. And you get to ask the people who are sort of the front facing in front of the patient, really what's important to your patient? What sort of things do you need to better understand to really convey information, accurate information, in a way that's digestible and for your patients to really understand. So certainly team science is of course most important, and having clinicians in the room right from the beginning, I think is very, very, very useful.
I totally agree with that. I don't really have much to add to that, but I also think that adds innovation as well to be in the room together, because one of my dreams for environmental medicine is to move it more towards the intervention aspect and to really see how we, from a clinical standpoint, can mitigate exposures. And so I think being in the room and kind of adding that collaboration as well as that innovation can be really impactful for the field of environmental health.
Thank you. I love all of those answers. Those are really, really inspiring. So I think I have other questions, but I think we can see if there are questions online. Would you like to share an online question? We can go back and forth, maybe online and then in the room. I think there are a lot of questions.
Yeah. So a question from online is for the clinicians. How do you talk to patients about drinking water contaminants and risk reduction measures to minimize exposure to contaminants such as lead, PFAS, pharmaceuticals, etc.? And what specific recommendations do you give to your patients?
Yeah, that's a great question. And I think it's at the policy thing that we've already been talking about. And so something that we counsel patients in the PCU a lot is just checking their drinking water quality. And so there's a lot of resources to be able to do that. And then also I think something that's really important to think about as clinicians is a patient's monetary ability, because I think a lot of times in environmental health, there's a lot of things that you can do to mitigate exposures, but they can be really cost prohibitive. And so I think as clinicians, being able to work with patients to talk to them about what they can do for their exposures. And so, for example, in drinking water, there's a lot of filtration systems that you can do, but there's a lot of also cost-effective ways. So really talking to patients about what is in their means is an important aspect that I think we didn't highlight before, but I wanted to mention here. And so along with testing your water, there's other things you can do, but really within the patient's means.
Yeah, I totally agree with that. I think really understanding what the patient and their family are capable of is really important. And also to, in some ways, take away some of the guilt that I think comes along, especially we see it a lot in pregnancy specifically, and trying to really educate as much as possible, but remove that sort of idea that the patient puts themselves at blame sometimes for some of these exposures, and sort of trying to come down to their level to understand exactly where they're coming from that regard is really, really important to sort of mitigate that sort of guilt that they oftentimes will feel.
Take a question in the room.
Hi, thank you for sharing these excellent insights. I have a question for the panel from a research perspective. We know that there are different windows of susceptibility where gene and environment are always in constant interaction. My question is that we as a scientist, can we do research on things that once the damage has already occurred? For example, Dr. Jasmine McDonald described about an analogy about the car meeting the pothole. So once the damage has already been occurred during that susceptible window, is there any hope from scientific perspective to reverse that damage, purely talking from epigenetic standpoint? We know that epigenetic modifications are reversible and diet, exercise, and other interventions are helpful, but for perspective from childhood cancers, is there something that as the child progresses to early, during the life, something that can bring back those damage back to the normal homeostasis?
Well, I'll say when I talk about it, like when you have a 5-wheel car that you manufacture, it's a 5-wheel car. But when you talk about epigenetics, that is reversible. So you put a bumper sticker on the car, you can take a bumper sticker off the car. So I think when it comes to childhood cancer, it's about realizing that they themselves are now at increased susceptibility. Just like those who are diagnosed with early onset cancer, they have a much longer time to receive these environmental exposures among cells that are already susceptible. So I think what is not done that I really loved what was said about, we need to think about environmental exposures after diagnosis and what can people do after diagnosis. A lot of times we focus on the prevention, but there is a greater amount of survivors where no, you cannot reverse that DNA damage, but you can prevent worse things coming along. You can change maybe your diet. You can change household cleaning supplies. You can make sure you wipe down dust. You can change your personal care products. Once again, though, that's an individual thing that it should not be on the onus of populations that may not have the means to do all of this. Like buying safe pans is ridiculously expensive. So I also think it's up to us as scientists to also put the evidence out there so that policymakers have a greater strength and backing when they're trying to just eliminate choice of unhealthiness.
Sorry, the only thing I would want to contribute, and not to be a Debbie Downer, but some epigenetic markers are not reversible. And some of these changes are actually, we're discovering, heritable in the animal science. So that is concerning, but we're hoping that most of them are not, and that we can reverse them.
I have a quick question. Thank you, everybody, for your presentations. It was very informative. So, Dr. Thompson, you mentioned that you would like to have more interventions with patients. But it seems like the tone of what everyone is saying is that it really should come from policy. And so I'm wondering what policies are in the works right now, because the onus shouldn't be all on the patients. And, pans are expensive, and personal care products, depending on your race, ethnicity, are there's more carcinogens in one than the other. So I'm wondering what right now is being worked on in the policy, or what's the process.
So I actually will turn that over to Dr. Sarah Evans,
really?
because she is our advocate and our policy person. But I will say, I do think cancer patients are unique because so while policies kind of set a standard across of protection, sometimes during these unique windows of vulnerability, or after somebody has survived cancer, they do have kind of like this added susceptibility. So I do think there is also an important point for clinicians to really advocate for our patients and really add these additional protections that they may need above and beyond the policy level. That doesn't mean that we should not continue to advocate for additional policy changes, because they definitely need to happen. But I do think some people have these increased vulnerabilities, and we really, as clinicians, need to talk to patients about that. But yeah, if you want to add the policy stuff.
I do, but I will also let the panel answer this. But I was reminded during Dr. Khan's talk about legislation that's currently proposed in New York State that would remove PVC plastic and diethylhexyl phthalate from IV bags and tubing. And so that's been introduced in the assembly. And I think there really is, and it's something that actually has passed in California. It's feasible. There are replacement products that can be used. And so there are opportunities like that to educate, not necessarily advocate, with our institutional hats, but to educate decision makers about why it's important. And they really don't know. We're used to having these conversations in these settings, but they really need the education. And so I would also say a couple of quick things. One is to take a look at New York State in particular. I think we can have more influence in the state right now. Look at New York State Environment and Conservation Committees and Health Committees, and see what they have sort of on the agenda for this year for priority issues around environment and health. And then also get involved with your medical society advocacy. Often there's a policy and advocacy committee within your medical or scientific societies. I'm part of the New York State Public Health Association Policy Advocacy Committee, and that's a great way to stay on top of all of the things that are going on in the state that impact health. So those are kind of my 2 cents on that, and I'll let the panel add anything that they want to.
Yeah, and I wanted to add, we're often thinking about like federal policies, but as you mentioned, California is one of the biggest markets, and they're able to make a lot of policy impact. And I work closely with breast cancer prevention partners that kind of was on that bill for removing DEHP from IV tubings. And one of the things I would say as a scientist is to lend your voice to legislation, or to those who are campaigning, to those who are speaking to congressional persons, such that they have the scientific backing. A lot of times, like, we kind of close ourselves in, but if you open yourself up to those who are doing the work, those who are actually lobbying, those who are in the front lines, you give them more strength to their voice, and it can be as local as you want it to be. It doesn't have to be at the federal level that you see change happen in your communities.
Hi, first, thanks for everything y'all said. It's really cool to learn about. I'm an environmental health researcher. I currently live in North Carolina. But before that, I was a person who grew up in a cancer cluster in 3M caused by PFOAs and the water basin there. And something that I've noticed as a researcher now is the difference between local impact and local involvement with your government as very differential in different contexts, right? Like Minnesota had a really, really different reaction to PFOA exposure than North Carolina did, with Superfund sites affecting the drinking water in the Jordan Lake area, or the Research Triangle area. And I'm curious, from the research side, right, how, if at all, y'all have examples of partnering effectively with policymakers, because I've heard from them similarly to clinicians that it's useful to be involved earlier in the process, but can be actually really difficult to do while still achieving kind of the aims of research. So would just love to hear your perspectives.
Well, I'll say that I am one to always know when they don't know. And so when the clinicians say they need to be at the table, I was very interested in looking at environmental exposures during pregnancy through postpartum. So I made sure that I had the community that was very interested in the topic, as well as just when I was communicating this to the participants, I also had to make sure that I wasn't using such high level scientific, and I also had to make sure that it was feasible, like doable. So I talked to everything from millennials who were working in clean products. I talked to clinicians about like what was feasible, what was like preferable. I talked to community organizers, what they wanted to see. I talked to nonprofit organizations, and we kind of created a very complicated, multilingual health intervention. And it was very small scale, but what it taught me is that everybody had a voice, and we did see declines in the education we provided in their phthalate levels over time. And so while it was a very complicated study design, I do think it's scalable because everybody who participated had a buy-in. So I knew that I wanted urine because I'm a molecular epidemiologist, but I knew that the community really wanted to see representation from them. They wanted this to be about persons of color who are constantly putting perms and relaxers in their hair. And so that was what they were interested in. But then I had environmental researchers who were saying pregnancy is what matters. Like that's where we really need to intervene. So I think as a researcher, you have to be open to recognizing what you don't know and willing to work across conversational lines. And it's gonna take a lot. You're gonna be frustrated, but it creates the best science that benefits all parties.
Is there an online question?
Sorry,
Wait,
I,
oh,
I,
sorry,
just,
go
I just
ahead.
wanted to add, I think that the kind of community-based participatory research that Jasmine just described is essential. And I would also say that community-based organizations can be really effective coalition partners when you're trying to make policy change. They are often highly organized, they're highly motivated, and they are the voters in their jurisdiction. So when they get together and talk to their representative, the representative has to pay attention. One scientist, very nice, whatever. I mean, it's true. You may, spend most of your days with people who have some kind of D after their name, PH or M, but to policymakers, so we don't think much about those degrees, but policymakers are like really impressed. So you actually have a stronger voice than you realize as a scientist to go and speak to them. Sometimes we feel a little intimidated, but actually they're really intimidated by us, which is nice sometimes. But I do think that these coalition partners, community-based organizations, environmental organizations, this is the team that you need to build to really take effective action with policymakers.
Did you want to, are there questions online? I don't want to overlook. Do we want to take a question from?
So a sort of technical question from, or methods question from online, I guess, for the clinicians is how can clinicians document environmental history information in the health record? Are there forms in the chart you use? They talk about how it'd be great to capture this information discreetly for secondary analytics. And do you bill for this additional consultation and time with the patient?
That's such a good question. It's something that we wrestle with all the time. So right now that everybody kind of does it differently. And I think it depends on what type of environmental health history you're taking. So in my clinic, environmental health history and occupational history is everything. So it's literally just my note, my clinic note. But for other people, like I said, putting it into like kind of the social determinants of health is a great place. Some people are working on developing environmental health screeners that'll, kind of do the preventative aspect of environmental health history taking. So it really hasn't been standardized, and I think that's something that we need to work towards as clinicians, because then kind of to the other point of that question, then you can start data mining it. So for example, in occupational health history, I think there's a lot we could learn about occupational exposures and cancer risk, but the occupational exposures are really not documented in a way currently that we can do that. And so just being able to document these things can really help learn about and inform, kind of the research on these issues. And so I think it's kind of an ongoing question. And then relating to billing, so again, it kind of depends, but in our clinic we use time-based billing, and so it kind of gets wrapped into that. But we also are in the PCU kind of always exploring different ways to do the clinical billing. So it's kind of an ongoing development in terms of how you get paid for this type of work. If Chelsea or Dr. DeBolt, if you want to add something.
So similarly for us, I would say we usually wrap in some environmental health history questions into sort of almost the social history. So we'll ask about occupation, especially for our initial prenatal visits. We'll ask about lead exposure. And our highest risk populations will just automatically send lead level at the initial prenatal visit. So some of these things are a little bit built in, at least in the prenatal population, in terms but we don't have like a long form the way that we do for some of the other social history aspects. And that's something that we think about, especially when we think about research in this space, because at least in our EHR, you can kind of easily pull from that if you kind of have like just yes, no tab-ins. And so it's definitely something that has been talked about and should be considered. And same for us for billing, we do bill by time. If we find something like elevated lead exposure, let's say, or concern for, or an elevated lead level at the initial prenatal visit, we bring the patients back for an additional consultation. So it usually is an entirely separate visit because it does require that much time, or we do refer patients out to like ACMED docs as well, who can oftentimes do a better job than we can.
We want to take another question from online and then maybe one more question from the room? Or
Sure. Yes, just trying to decide which one. Someone said that they recently participated in a STEEP webinar, which Silent Spring is involved with, where the tribe's natural resource director stressed combining traditional and scientific knowledge in relating PFAS levels in drinking water and fish to negative health consequences. So the question is, how does medical research mesh these two interpretation and action schemes for toxic chemicals on reproductive health?
I'm not familiar with the traditional methods for interpreting environmental exposures and their effect on health, so I can't speak to that.
maybe we can come back to that one. Or Dr. McDonald, did you have?
Oh, I'm not sure. I guess I'm not also familiar with the STEEP.
Yeah, STEEP is like it's a research collaboration, which Dr. Shader, if people have questions, can ask her during the break. But it's focused on PFAS around a Superfund site.
I see.
The tribe is one of the partners.
I see. Okay, so I don't work with PFAS as much, so I wouldn't want to give a false or an inaccurate response. But it seems like there's people here who could possibly give an answer. Would you like to give an
Thought I wasn't speaking till this afternoon. Yeah, so that webinar focused on ways that, so our partnership is with the Mashpee Wampanoag tribe on Cape Cod, and they have a program where they combine Western science and expose youth to, Western science as well as traditional knowledge. So it's a great question exactly how to convey information about toxic chemicals. I don't think we exactly got into that. Through a different Superfund research program, I think based in New Mexico, I remember there was an artist there who used artwork and conveyed information about, they used, it was visually showing DNA damage with beadwork with a Native American artist. So I thought that was an effective way of bridging those ideas together and visually showing DNA repair and with beadwork. So I thought that was a great example.
Very cool. We have a question over here, so I don't want to miss it.
My question's more for Dr. DeBolt. I I was wondering, I know you have a background in maternal fetal medicine as well. So when patients have like higher risk pregnancies, and I know in your bio it said you work with like preeclampsia, I'm just wondering how you're able to stress environmental risk factors in addition to maybe something that's a little bit more pressing. And then I guess the second part would be, I know there's like immunological changes in the placenta with preeclampsia. So I'm just wondering if there's any factors that also show up in terms of environmental issues in the placenta and like how that is differentiated.
Great question. So, in terms of, I guess, sort of like prioritizing is sort of the question when there's a high risk pregnancy. We try our best, really, ideally, you see someone for before they're pregnant if they have a high risk issue, because it allows you to really give them the layout of what a pregnancy may or may not look like for them and the sort of risks that they may endure during that pregnancy for them to actually be able to make the decision regarding whether they would like to be pregnant or not and take on those risks. In terms of environmental exposures, we do try to incorporate that like really early on. So at like the initial prenatal visit, we know, at least from like, for instance, a workflow standpoint, those visits are definitely much longer than any sort of return visit. In our practice, we do have the ability to bring people back and do video visits for very pointed, like specific issues that we need to discuss. And again, really leveraging as best we can the preconception period or even post-conception period is ideal when you're laying out risk for patients. But in terms of EH, if we like I said, sort of if we find that there is something that requires much more detailed attention, we don't sort of incorporate it into what I would call like a routine visit or even an initial visit. It requires a totally separate visit, discussion, and potentially even a totally separate clinician to do some of that investigation and follow-up and taking care of that patient. In terms of the placenta is a very obviously pregnancy-specific organ, and sometimes one of the most challenging things in pregnancy research is chicken or the egg. So, is the placenta are the findings in the placenta the cause of the problems we're seeing, or are they the result, right? So things can accumulate in the placenta, just like you mentioned. A lot of environmental exposures, heavy metals. We know the placenta also is the crosstalk between mom and fetus, and so there's a lot of things that go between. We can utilize things like umbilical cord lead levels and metal levels and things like that to get an idea of the exposure to the neonate, and we do see that the placenta is a very well-tuned organ, and so we also know that there's very specific receptors, and it has a very specific job in sort of being the moat around the castle and really kind of keeping bad things out. And so it's hard for us sometimes to really determine, is this accumulation of something in the placenta, was it actually bad, or was it the placenta doing its job, right? Keeping it out and away from the fetus or the neonate once the baby is born. So the placenta is a very, very, very tricky thing to study. Again, mainly because we can only study it after the delivery has happened. Unethical other than for genetic testing to test the placenta during the pregnancy. So we don't have the ability to really do that from a research perspective. And then other data that we really get from placentas are usually from terminated pregnancies. And in those cases, you don't have pregnancy outcomes. So it is a complex sort of circular chicken or the egg picture. And I will tell you that that is the question that's always sort of being asked, especially in a disease like preeclampsia.
Okay, thank you. I'm not being a very good timekeeper, so we have to wrap up and go on to our keynote speaker. But thank you so much, and I hope these conversations can continue at lunch and in the subsequent panels. And the speakers will be sharing their slides and additional resources after the conference, so you'll have opportunities to follow up and get more information. So I think I'm turning it over.
Sorry, for those of you online, we have just a quick change in the schedule. So we are going to take a very quick break right now, and the keynote lecture will run from 12 to 1. We still will have plenty of time for lunch. For those of you in the room, we'll have lunch right outside here from 1 to 1:30. But we will be doing the keynote lecture from 12 to 1. And I'm sorry about that confusion, but yes, we will start in just a few minutes. Okay, great. Thank you. So you can take a quick break. The bathrooms are right around the corner, and we'll do from there. Yeah, sorry.
I never saw this. Yeah, that's true. You're right. They're probably.
Yeah. Okay. Sorry. Moving parts. Yeah. Okay. All right. Okay. Sorry about that. Yeah.
Awesome, great. I guess just like if you are by they should be able to find you, right? Like they know you. It's a small room, so they can just come find you. Yeah, I'll do that. This room is really small. So those two things that she posted on the Google Drive, she won't be able to see.
I didn't think they did. There was the detox me,
Maybe we'll let him sit down. I have some warm-up questions too. In case you didn't know.
I know, I tried to tell you, like. Yeah.
It's much better to have the break.
Yeah.
Okay, and we have plenty of time for lunch.
Yeah.
Okay, all right, so you're gonna introduce Jeff, I mean, like,
So
talk
I have
about
a few
Jeff.
words about
Oh, wow,
him.
okay, all right.
I mean, we'll go
Okay,
quicker than
why
Lex.
don't you do his whole bio? Because I've been doing bios all day. I think that's great.
I would rather you do it. I didn't really prepare for it.
Oh,
so
yeah,
I'm
no
doing
problem.
This.
I'll do it. Yeah, so
and I think
this-
it's nice anyway for you.
Okay, yeah, I'll do this. This is different than the bio we have, but
Oh, it is? This is the one that Kim sent me. But use whichever you have. Use it. Oh, is this on?
Oh, yeah, okay.
Use whatever you have. It's fine. Yep.
Yeah, no, this is good. I think it might Okay. I'll use this. Okay. Oh my gosh. All right, okay. And then you're taking him back. Or he's taking him back. Okay, right, okay. All right, and you know him from when you worked at Sinai. Did you just meet him just now? Okay. All right, and is there anyone else you wanted to meet who's speaking today? Okay, all right, okay. All right, so I'll put this right here.
Come on in, have a seat. We'll get started in just a minute.
Floating around. So once the talk is done, I can try and grab it, and if anyone hasn't been able to sign in yet.
Okay. I have to man this, so I can just let you be in charge.
Okay. I just want to let you know.
Yeah. Thanks.
You want to just tell everybody,
So I was going to do this and then introduce you.
oh, sorry, I don't know where I put my phone. Sorry. You don't have to introduce me. It's fine. No. Okay.
Sure.
All right, okay. But we should start because of the online.
Okay, if everyone could please take a seat. We're going to get started now. And if you could please kind of shift to the middle and leave the end seats available for latecomers. Okay, if you could please go ahead and take a seat and sort of move to the middle of the rows, if possible, to leave room for the newcomers. Okay. Well, I'd like to warmly welcome you today to the Jeffrey R. Howe Memorial Lecture. And thank you to the Cancer Center and to Silent Spring for co-hosting this event with us today. The Jeffrey R. Howe Lecture is special to the Department of Epidemiology. I'm an associate professor in the Department of Epidemiology, Teresa Yanovich. And Dr. Howe is what we consider a legend in our department. And he also was chair for a number of years of the department. So this event is important to honor our history and sort of our legends and how they shaped our department today. Dr. Howe also more broadly was a legend in environmental epidemiology, so it's especially fitting for this lecture to be in conjunction with the Cancer and the Environment event that many of you attended today. So for some of you who are colleagues and friends of Dr. Howe's, I'm going to say a few words about him, and these words will not be enlightening, but for many others here maybe had never heard of him before, and so this might be the first time you're acquainted with Dr. Howe, so I'd like to just say a few words. Dr. Howe was one of the world's leading radiation epidemiologists whose early research on cancer incidence among atomic bomb survivors shaped the foundation for the field. He was subsequently chosen by the NIH to lead research on the cancer effects of the Chernobyl accident in 1986. But he was also an expert in diet and cancer, and he conducted foundational case control studies on diet in both breast and colon cancer. And later, he started one of the first prospective cohort studies of diet and cancer. But alongside this impressive epidemiologic body of research, the description of Dr. Howe that struck me the most, I found in a remembrance essay in the journal Epidemiologist, which was authored by Elaine Ron and Walter Willett. They said, Jeff traveled widely, lecturing, exploring, and learning with enthusiasm and irrepressible curiosity. As an educator of epidemiology, this gave me chills. I realized, in addition to being capable, this is the essence of what we want our students to walk away with: enthusiasm and irrepressible curiosity. A second comment about Dr. Howe in that same remembrance also struck me. The same author said, Jeff regarded differences in perspective as opportunities to learn. For him, debates were platforms to exchange ideas, which he did with irony and good humor. This is another critical lesson, not only for the students in the audience, but for all of us today in the audience. So with that, I'd like to turn over the mic to Dr. Mary Beth Terry to introduce our guest lecturer today. In addition to being a professor in the Department of Epidemiology, she's Executive Director of Silent Spring and Associate Director of the Herbert Irving Comprehensive Cancer Center. Thank you.
Thank you so much, Teresa, and thank you to all of you for attending this memorial lecture. I had the great honor of being one of Jeff's students. I was also one of his teaching assistants, and I also loved running into him and his wonderful dog almost daily on the subway. So for those of you who didn't know him personally, he was the most brilliant cancer epidemiologist that I ever had the chance to work directly with. And he taught me everything I knew and hopefully still know about data analysis. So without further ado, I can think of no better person to represent Jeff's memory in our field as Dr. Paolo Buffetta. Dr. Buffetta graduated in medicine from the University of Turin and obtained a master's in public health right here at Columbia. He's currently professor at Stony Brook University, who is also co-sponsoring this CME, so thank you to them. And he also is on faculty at the University of Bologna, and he has current appointments also as an adjunct at Harvard and many other places around the world. Truly, anything that you want to know about cancer epidemiology, Paolo has written about. So he is a prolific writer. He has published over 1,700 publications in the peer review literature. He's edited over 1,600 books. Sorry? Oh, did I say 1,600? You're keeping me honest, Paolo. But soon it will be 1,600 books, knowing you, because he never stops. And right now he has really transformed in his various roles, both in academic leadership, but also in global leadership at the International Agency for Research on Cancer in Lyon. He has established some of the most important cohorts around the world for answering questions about the environment, occupation, and modifiable risk factors for cancer. He has started the Lung Cancer Consortia, the Enhanced Head and Neck Cancer Consortia. He's worked very closely on the pancreatic and esophageal cancer cohorts. So these cohorts are addressing both common and rare cancers, and all of the work that these consortia have done have really been very much benefited from Dr. Buffetta's scientific leadership. And so he's worked for the last 3.5 decades, has grants here in the US and Europe. He's worked with the National Institute of Health, the Center for Disease Control and Prevention, the Department of Defense, and also various charities around the world, including the World Cancer Research Fund. Again, if I were to tell you all the accolades and awards he's had, it would take the rest of the hour, so we won't do that. But I will say that one of the things that I love about New York City is that Dr. Buffetta, who clearly is one of the most prolific international cancer epidemiologists, took the subway here. So thank you.
Okay. Well, good afternoon. And thank you very much, Mary Beth, for the invitation. I'm really honored to be here, to be part of the Environment and Cancer event, CME event, but even more to be the lecturer for the Jeff Howe Memorial Lecture. I've been knowing Jeff. We met across, in several occasions. We never really worked closely together, but we were sort of involved in several collaborations together. So I always respected him. I admire him. I think I've learned a lot from him, both directly and through his papers. In fact, when I was here at Columbia, Jennifer Kelsey was the chair, but then Jeff succeeded a few years later. So I was keeping a lot of contacts with people here. So I was coming back often and talking to him. For example, at the time of the New York of the Long Island breast cancer study, I remember having had several meetings with him, talking about this important project which was going on at that time. Okay, so when Mary Beth asked me to talk about environment and cancer, I had, I've been thinking what to include in the lecture, and I'm afraid I put too many things, so I will have to go a bit quickly, but I will try to give you several, different perspectives on how epidemiology can contribute to the prevention of cancer through the study of environmental exposures. These are some disclosures. As well, Mary Beth has already said that I've been working under research grant and I've been doing some consulting with government and non-government institutions. So one important feature of the epidemiology of cancer is that mortality is going down all over the world, or at least in basically all countries of high or very high development. And the US is leading this trend. You see here, these are the trend over the last 25 years or so. The decrease is about 1% per year, both in men and women. It's a bit stronger in men because of lung cancer. Lung cancer is still the dominant cancer in terms of mortality for men and also for women, and it's been more important for men. If we take out lung cancer, we see that the trend is basically the same for men and women. So we gain 1% of cancer death per year. Not really in terms of numbers, but in terms of rate. I mean, these are rates. Numbers are less because the population is aging. So obviously there are more and more cases of, death in the older people. Okay, a few years back, 2 or 3 years ago, I did this analysis of the SEER data with a student of mine, and we looked at, do I have a pointer somehow? Okay, you see it? Good. So what I did was these are the trends in mortality from some of the key major cancers. They're all going down with the exception of liver cancer, which is one of those going up in this country. And what we did was to try to disentangle this by looking at the effect of incidence, so the effect of primary prevention, if you want, the effect of change in stage distribution, so the effect of screening or early detection, downstaging, whatever, and the stage-specific survival, which may, somehow relate to treatment, advancement of treatment. And the key point is that, most of the trends are really related to incidence. So mortality parallel incidence, there is some effect of improving stage distribution, and there's been a lot of effort done in improving screening in particular, but also improving early diagnosis in downstaging. While the effect of cancer survival is there, but is not significant for some of the cancers, and it's not very strong in terms of coefficient, as you see. So I think that's a very important message for us as a public health and epidemiologist, because really primary prevention, avoidance of developing cancer remains or has been the driving force in the improvement of the the cancer picture, at least in this country, but probably that's the same for many other countries. So these are the trends for incidence. For incidence, the picture is a little bit different. You see there has been some decrease, in particular for men, but also some increase in the last few years. And if you look at specific cancers, you see, for example, breast cancer, incidence has been going up a little bit, while liver, as we said before, and also pancreas is the other cancer, the other important cancer, which has been, whose incidence has been going up. So there are cancers that are still increasing, and we do understand some of these trends, however, not completely. And this story that we don't understand very well, the major trends, for some, obviously, we do understand, tobacco-related cancers. I will show some examples later. But for some other, we really don't understand. This is one example. I've been working a bit over the years, is non-Hodgkin lymphoma. These are the trends for men, women, green and blue, and the red is the middle one. If you look at the first part of the picture, the incidence of NHL has been going up across most of the developed countries. And at that time, I was doing some large international studies. I was running a study in 6 European countries and created a consortium with people from NIH, really from NCI, really to try to understand why NHL was increasing. And there were many hypotheses related to immunological surveillance, possibly environmental factors, infections, etc. And we couldn't really come up with a very strong explanation. But in the meantime, where we were doing these nice AP studies and try to publish papers in nice journals, the trend changed completely. And by mid-2000 or whatever, there was a change in the pattern. And this was totally unexpected and is still going on. You see there has been a 1% increase in the first part, which is basically the last part of the 20th century, and now a sort of short, somehow a statistically significant decrease. And this has been observed all over the places. We even published a paper, which I use as an example in my lectures, when in the 90s, early 90s, we projected the number of NHL deaths or cases in many countries, and they were all going up. And then, as you see, this was totally wrong. So doing prediction in epidemiology is a good way to get something really wrong. And the same is happening for other important cancers. We heard a little bit about childhood cancer in the first panel. These are the trends for total childhood cancer, all types, and there are very different types, as you know, but it's dominated by lymphoma and leukemia, the two most common ones. And again, there was an increase, which was about 1% per year, as you see here. But then also this one has changed over the last 10 years. And really, we do not understand what is going on here. Maybe related to diagnosis, perhaps there was some improve or increasing diagnosis or whatever, but clearly there is a picture, and I'm just giving a very high-level picture. Obviously, no one can go into more details, but clearly there are major trends that we really do not fully grasp, and we need really to try to get into this as much as, into more detail. And then we'll come back at the end discussing how we can improve, our research. So let's move on to a slightly different topic, which is related, however. So how many cancers we can attribute to known causes? I mean, if we take out all the known causes of cancer, if nobody smoked, all the people had a healthy diet according to the recommendations that are supposed to decrease cancer risk, no occupational environmental exposure, blah, blah, no infections, how many cancers we can take away, or at least how many of the current cases would have been avoided. And these are the numbers, not very high. These are different studies done in the last 10 years or so. I did 3 of them, the one in Brazil, in China, and in Italy. And the USA results are done by the group of the American Cancer Society, just published 1 year ago. But the numbers are similar. They are somehow higher in the Chinese study because of the role of infections, basically. Hepatitis B, Helicobacter pylori, and HPV, papillomavirus. But if you take out the infection, the numbers become similar. So we roughly understand about half, or maybe a little bit less than half, because for women, the issue is a bit more complicated because of the hormonal-related cancer that are a bit more difficult. But anyway, let's say about half of the cancers can be avoided. And let's keep this 40-50% in mind. Keeping this, I did this exercise, which I just updated here with some of the more recent data. So these are the rates of cancer in the US, okay? About 320 per 100,000 in men, about 300 per 100,000 in women. If we take out this fraction that can be prevented, this 40% or whatever, we can go down to these numbers, okay? So we can say if we had done everything right, at least everything we understand, we know that is going to have an impact, this would have been the cancer we would observe today in the US. Okay, and then I go taking advantage of my international experience. As Marybeth says, I work at the IARC for about 20 years. We have this very nice collection of high-quality cancer data across the world. So I went to look at the lowest rates recorded in some place on Earth, and it happens to be in this area called Barshi, it's a rural area in Maharashtra state, west of Mumbai, and these are the rates, about 50 or 60 per 100,000. There may be some underdiagnosis, although this is a registry which has been really supported very heavily by the government and the Tata Memorial Center, the best cancer center in the country, really to get good data in a rural area. So there is a huge gap here. You know, obviously we might not hope to get all to the very low level of cancer observed in a rural Indian population, but clearly there is a huge gap, and we could do something, you know, to get closer to these numbers. And by the way, Barchi has a relatively high incidence of infection-related cancers, for example, HPV in particular. That's the reason why women are higher, and this is not the case in the US. And if we do this exercise for specific cancers, these are in men. I just put, you know, the blue bar is the observed rates in the US. The orange is the observed minus the preventable, and for prostate is 0, as you see, because we really don't know what is causing prostate cancer, but for lung is obviously 90% or whatever. For colorectal is about 50. And you see that the Barshi rates are still much lower, you know. So there is something that we do not know which is causing much more cancer. Oh, by the way, there can be some genetic component. I mean, we can discuss this, but again, the difference is so big that, you know, there are obviously many modifiable, avoidable risk factors out there that we don't fully understand. Okay, I think I can skip the, no, well, the only reason to show this slide, which is basically the same as before, just broken down by the major groups or risk factors, is to show that, you know, in this exercise, people, including myself, came out with a relatively low proportion of cancer due to environmental pollutants. And these are really this environmental pollutant in a strict sense. So water pollutant, air pollutant, etc. It's probably an underestimate. You see it's very low. It's about 1% of these 40% or whatever of the total. But which, again, is a good example of something that we don't really understand fully. And I'm just using, I mean, the people involved in these projects have been using the sort of the well-established risk factors, you know, like IR category 1, for those of you who know this classification, or WCRF, highly, whatever they call it, you know, sufficient, or whatever they call it, highly convincing evidence. So let's focus a bit on the environment now. I think there is some ambiguity, because sometimes people talk about environment in a very broad sense, in basically everything which is external to the body. And in this case, clearly it plays a role major role in most cancers, you know. And then there is a more narrow definition, which is the surrounding conditions in which we live or operate. And obviously there is a continuum between these two, and we just heard about, you know, diet and the components of diet that can be considered environmental although, to some extent they may be natural and to some extent they could be industrial result of industrial process, etc. But we should really try to understand what we are talking about when we talk about environment. I will focus more on the more narrow definition, the more specific factors, but we should keep in mind that, obviously they interact, with the larger picture. These are the so-called group 1 carcinogens according to IARC, so the agents that have been classified by IARC as human carcinogens for which the general environment is the main source of exposure. Obviously there is, again, it's hard to separate completely environment from, say, occupation or diet, and again, it depends how we want to define environmental factors. But if we focus on, so these are the about 10 or 12, agents, including some which are very important, like ionizing radiation, outdoor air pollution, second-hand tobacco smoke, UV radiation, and some which are more specific, like, some of these fibers, etc. So we know about 12 or so carcinogens with, several target organs, which I listed here. And then there are a number of agents which are probably much more diffuse in the environment, but they are also mainly occupational carcinogens. So things like asbestos, benzene, diesel, they are all part of environmental pollutants and they are important, but the exact quantification with respect to other source of exposure becomes more complicated. And in a way, it's something that we should really keep in mind. And in fact, well, this is basically repeating the same story. So some of these environmental pollutants, we really know what we know in terms of, the potency, the dose response, all these from occupational studies. And we are extrapolating data mainly from occupational studies. Instead, for the indoor pollutants mainly, we are focusing more on the indoor, actually, on the indoor environmental factors. So I don't have time to go through all these, obviously, so I selected just a few examples. The first one is air pollution. Air pollution is probably known to many of you, have been involved in some of these studies. I focus in mainly on lung cancer. So the main evidence comes from cohort studies, where the exposure has been measured very much based on place of residence. There is a little bit of validation via biomarkers, but it's very, very limited. So we basically have data on where people lived and combining this with some modeling based on dispersion of air pollutants in different, with a lot of mixed classification coming out, and we'll talk about this in a minute. Individual studies, despite the fact that lung cancer is a common cancer, are relatively limited. And these are some of the issues. Most of the data, the best data on environmental air pollution are on agents like NOx and SO2, which are not carcinogens. And we really want to have more data on fine and ultrafine particles. And these are available only for the last few years in most settings. As I said, exposure assessment is mainly at the ecological level. It can be sometimes it's even county, then hopefully sometimes it's a more detailed, like, typically zip code, sometimes, even more detailed at the level of the address of the census tract. There has been some effort to try to disentangle the contribution of specific sources of exposure, like diesel in particular, because diesel has some components that are the nitro-PAHs that are more easily to separate from the rest. And one important aspect is that, the same carcinogens in air pollution are present in other issues, in other agents, such as tobacco and occupation in particular, and also socioeconomic factors, economic factors are potentially related to air pollution and carcinogens. So we can maybe discuss this in the afternoon. So these are just one example of a recent meta-analysis we did on PM2.5 and lung cancer. These are the relative risk from large cohorts published in the last 20 years or so. So these are all based on relatively precise estimate of exposure. There is, as you see, some variability, some heterogeneity. But anyway, as in other meta-analysis, the overall estimate is about 15% increased risk of lung cancer per 10 microgram cubic meter increase in PM2.5. However, again, as I said, exposure misclassification is a major issue. And I'm just using outdoor air pollution as one example. Many of these considerations would apply to other environmental carcinogens. So, the use of ecological data, as I said, clearly introduce misclassification. There has been some attempt in more recent cohorts, to try to go more into the individual level, but then people don't stay all the time at their place of residence, so it's a usual problem. And then time spent in different locations, etc. Overall, this is likely to be non-differential and to lead to an underestimate. However, there are other issues that may go in the opposite direction, other sources of bias. For example, the use of recent exposure data. Air pollution has been going down, fortunately. At least PM2.5 has been going down in most countries, including the US. This is an example of a sensitivity analysis done in the larger CPS2 study of the American Cancer Society in one of their papers. And you see that when they used the more recent exposure level, which obviously differ, but the mean was 14 at that time in the US, now is about 8. The relative risk was 1.11. When they used older data, which were probably more relevant, by the cancer outcome that were studying this cohort, the relative risk went down about 1/3. So, the excess risk went down about 1/3. So, clearly, the use of exposure data is complicated and may introduce, bias. Residual confounding can be another issue. This is a nice paper, again, based on the CPS2. The big graph here is the dose response for active smoking, which is nothing particular. But then when you blow up the the low-level data here, you see that, the line is the extrapolation from active smoking. These two dots are the results on secondhand smoke, and these are the results for air pollution. And there seem to be some over risk. Either air pollution is more carcinogenic than tobacco smoke, given the same level, or maybe there is some residual confounding that may bring this level up. So, and by the way, another indication is the problem that, for example, in our meta-analysis, but in other meta-analysis also, the main effect of air pollution seems to be restricted to smokers, and to, in particular, to never smokers. So this is probably indicating, sorry, this is against confounding, because for current smokers there seems to be no effect, which makes sense, because probably there is the same, an additive effect of the two exposures. So these are some, well, I don't need to discuss publication bias. So anyway, if we believe that there is this 15% increase in risk of lung cancer for 10 microgram cubic meter, now we have the average exposure about 20 years ago, when we might consider 20 years latency, was about 12, as we said before. So the attributable fraction will be 0.16% of lung cancers, which are 16%, sorry, of lung cancer, which would correspond to about 22,000 cases per year, or 0.8 total cancers. And if you remember, the estimate of total effect of environmental factors was less than 1%, which is clearly an underestimate, because when you start to go into the detail, you see that air pollution alone is about 1%. So it's not huge, but it's sizable, and 1%, preventing 1% of cancer is something good, important, and not so easy to do. We had several success in cancer prevention, not very often getting to 1%. Okay, I use a second example, which is PFAS. because this has been a lot of discussion, and we heard already, maybe we'll hear more in the afternoon. PFAS is interesting because the exposure level has been going down a lot in the US. These are data, international data from PFOS and PFOA. The US results are the pink ones, the big pinks, so we can just focus on those. And you see that, between 2000 and 2020 or whatever, there has been more than threefold decrease in the level of PFAS measured in blood. These are typically enhanced, different phases of enhance, So this is obviously very good news, and is a result of largely due to the ban of these compounds in the 80s or late 80s or whatever. So this has been going down, and the cancer which has been more strongly associated with PFAS is kidney cancer. And in fact, the kidney cancer has been one of the cancers which has been going up with a possible, downturn in the last few years. So clearly, if PFAS causes kidney cancer, it causes probably a very small proportion, and it's not visible, in terms of population statistics, and we really need to look into more detailed studies. These are the meta-analysis we did 2 years ago on PFAS and kidney cancer. And now there are a couple of more studies, but the overall, because this was at the time when IARC did their evaluation, but they didn't do a meta-analysis, so we did it with a student of mine, and also for people from Brown, and you see the data were really pretty catchy. There were different studies looking either at PFOA or PFOS or PFAS in general. The definition of exposure was not really totally consistent. We found an increased risk, which may be true. However, there was really no dose response. There were four studies showing, results per different level of PFAS in blood or whatever, and there was no relationship. And also, publication bias remains somehow a possibility, because when you look here, you see that, most of the smaller studies are in the positive direction. So I think there are some issues to consider, but clearly, more and more evidence is accumulating. However, if we believe that PFAS causes kidney cancer, which may indeed be the case, the relative risk for about 400 nanogram milliliter exposure, one of the best quantification of the excess risk, was about 2. And if we just look at the average level of PFAS in blood in the US, it comes out that, there will be a very small number of cases. Now, whether this is true, I don't know. There are many more uncertainties here, but to me at least says that, it seems to be a potentially important cause of cancer, but probably not so diffuse, not so widespread in the population. Okay, I move now to a different topic, which is some examples of how epidemiology has contributed to the prevention of cancer. And I will use 4 examples, try to go very fast. The first one is liver cancer and hepatitis B. That's a wonderful story, one of the biggest success, I think, if we leave aside after, tobacco and maybe HPV. So the first cohort study linking HPV to liver cancer was published by Beasley in the Lancet in 81. It was a cohort of government employees in Taiwan. 3 years later, Taiwan government started to vaccinate newborn to mothers who were carriers, and then expanded the program to basically the whole population. And this has a huge impact. You see, this is the percentage of vaccinated children, which was obviously 0 and went up to about 85 to 80%. And this is the prevalence of HPV at 6 years later, based on the date of birth. And, this is where vaccination started. And basically, prevalence dropped from 10% to 1%, thanks to vaccination. This happened in about 30 years ago, so now we can start to see what happens in terms of liver cancer prevention. We do see this. I think this is amazing. These are the rate of liver cancer up to about 25. Obviously, this cohort of vaccinated children are getting older now, so we are gathering more and more information. But you see that the rate ratio was about 0.4 between the non-vaccinated and the vaccinated cohort. And then when we go to those born in the last years, which was a higher coverage of vaccination, the relative risk is 0.1. So this is reducing liver cancer incidence by 90%. Liver cancer was the most common cancer in this population, and just with one intervention, epidemiology identified the risk factor. It was possible to prevent it. It was done, and now we are cutting. They are reducing 90% the incidence of the most important disease. So that's amazing, and it shows really the power of epidemiology when things really line up in the right way. Now, second example, mesothelioma shows how more complicated things can be sometimes. So we all know asbestos is the leading cause of mesothelioma. There has been, it's mainly been occupational exposure, has been heavily regulated since the 80s, basically. Some countries a bit earlier, some countries a bit later, 80s, 90s, or whatever. So now, again, 30, 40 years have passed. Let's see what happens in terms of mesothelioma. Are we seeing the same effect that we saw for liver cancer in Taiwan? So we did an analysis a few years ago on the trends of mesothelioma mortality since the different countries used ICD-10, because before there was no code for mesothelioma, and we did it for the countries with high-level death certification. So these are the trends for men, the top one, and for women, the lower one. Well, we go down, we go to 2014, 2015. We don't see such a dramatic decrease, and 2014 is 30 years after cessation of exposure. Well, some countries is going down a little bit the US, UK, Australia, but, the other countries. So why so? Is it not true that, preventing people from being exposed to asbestos does prevent mesothelioma? And in fact, it is true, but the characteristics of the disease are so different that, really we need to have additional consideration. These are the trends for the young. These are the young people, and you see how beautiful it's going down. This is really the effect of prevention again. Take out asbestos, 30 years later, there is no more mesothelioma in young people, or less and less, fewer and fewer, whatever. It's getting basically close to the rates in women, which were probably not related to occupational exposure to a large extent. So it does work, obviously, fortunately. I mean, we have strong evidence that it does work, but only the young people. And these are the people who enter the workforce largely after regulation was implemented. If we look at the older people, those 75 plus, we see a totally different picture. These are people who were already employed when regulation started. So they were exposed, well, not all, but obviously they had opportunity for exposure in the early phase of their career. And yet cessation of exposure didn't help so much. So the problem with mesothelioma is a very, very long latency. The fact that early exposure in life cause an increased risk throughout the rest of the life. And this is exactly what we see here. So basically, the effect of long-term effect of fibers in the pleural and peritoneum. So we need really to keep these considerations into account when we want to understand how well, our epidemiological results have an impact in the population. Unfortunately, for these older people, older birth cohorts, health surveillance, remains the only way, really to have an early diagnosis or whatever. That's the different story. This is a third example, and Mary Beth mentioned this because she saw this an early version of this in a previous presentation. It's a nice, very nice story, the one of head and neck cancer in France. These are the rate of larynx cancer in green, oral and pharynx cancer in brown, and lung cancer in blue in France. The pattern for lung cancer is what we observe in many other countries, including this one. There was a maturation of the epidemic due to tobacco in the 70s, 80s. These are men. Men started to stop smoking, and 20 years later we see the decrease. Great. So we are able to prevent lung cancer by stopping smoking. But look what happened to the head and neck cancers. They started to go down like 20 years before. Why so? There was no other major public health initiative in France beyond, tobacco control. But there was, and clearly the other big risk factor is alcohol intake, a little bit HPV, but mainly alcohol. And there was no really preventive measures of alcohol. However, there was a stricter control for homemade spirits for taxation purposes. So the government really tried to stop what is called, homemade spirit brewing. And this caused a decrease in the consumption of alcohol in the country, which caused this major decrease in the rate. Look at the rate for larynx cancer. It was 10 here and has been now 1. So this is an example of a prevention of an important cancer, was one of the top cancers in men in that country, which had nothing to do really with our intervention, our advocacy, our work, what just happened because of other factors. Okay, I have a couple of other slides on alcohol, but I think we can skip. The last one is that stomach cancer. Also, stomach cancer has been going down very, very rapidly in all countries, high risk, low risk. And these are probably the contributing factor, but H. pylori infection control is a typical one. And that's, again, it seems to be a good opportunity to do prevention of an important cancer. In many countries, stomach cancer is still the number 3 or 4, in the top 3 or 4. And in fact, we don't know much about HPV, how to prevent HPV. There is also a lack of interest. There is no vaccine developed, is a little bit neglected, and yet is the main cause of infection-related cancer worldwide. And I just want to mention very briefly, one of the projects I'm doing in Europe is try to implement H. pylori screening at the workplace, to use the workplace occupational surveillance, health surveillance at the occupational setting to invite workers and their family members to be tested for HP, and then to follow up, those positive. And we are doing this study in 4. It's a study sponsored by the European Commission in 4 countries, which is going on at the moment. So it's typical implementation science. We know that HP prevention is important, but we don't know how to do it. Okay, so these were some examples of important causes of cancer which has been somehow addressed with the contribution of epidemiology in different ways. So shall we ever explain 100% of human cancer? We said we know about 40%, 50, maybe a little bit more. Well, my personal opinion is that probably there is a proportion of cancer that would be untreatable with epidemiology. We cannot discover them. Can be related to the aging process, can be just chance, can be endogenous mutations. Remember, there was a paper maybe 5 years ago saying that the majority of human cancer is due to chance, which is obviously not true, because otherwise we will not have all these nice results. But probably there was some true, and if you want, we can discuss this in detail. But I think if we don't fully understand cancer, we need to acknowledge this and understand this, and obviously try to study better, and just accept the limit of our knowledge at the moment. And how can we study better? And that's the last few minutes of my presentation. Well, that's just it looks like the syllabus of a AP study, didn't it? Increase validity, reduce outcome misclassification, increase precision. Okay, all these are nice things, but it can be implemented, and people are trying to do better studies, better case control studies, applying omics, try to study, intermediate markers, have large cohort and large collaborations, and I've been involved in many of these. Also study unique populations, and then the whole story of reducing publication bias, etc. I will just present 2 examples very quickly of 2 cohorts I've been involved in. The first one is really a very special population. Is a cohort in northeastern Iran, this area, which is part of the so-called Asian esophageal cancer belt. All these areas of Central Asia up to northern China had very high incidence of esophageal cancer, in particular in the past. We did a study with collaborators from Tehran and NCI, and including 50,000 healthy adults, 80% rural. So it was quite a challenging cohort, With, we tried to do our best to collect, valid data, validations, repeated measurements, etc. So this was during the cohort recruitment. You see, I'm here, even if I don't look the same, probably, but with the team, and this is Professor Malek Sadeh, the PI. So, these were the nutritionists, these were the team involved in the cohort follow-up. We had hot tea as one of the hypotheses to study. There were 2 or 3 key hypotheses. One was consumption of hot beverages for esophageal cancer, so we had to devise, some new approach for tea temperature measurements, just to give you an idea of the type of work. And this cohort has produced, important results. We really identify tea as one issue. We identify, where is it? Here, opium use as another major cause of cancer, esophageal and some of the other cancers in this population. And, when we put all our results together, this was a sort of overall paper we published a few years back. We really were able to explain much of the increased risk. So this was a successful cohort, which has been, by the way, used in many other for many other purposes. So it's one of the projects I really like the most. I'm very proud, to have contributed to this study. As you can imagine, it has gone through many political issues, with the relationship between Iran and the European or European US going up and down, but still we have been able to do a lot of good work. The second example is much closer to us, is the cohort of World Trade Center rescue and recovery workers, together with collaborators from the fire department and Albert Einstein and people from the Department of Health. We put together 3 cohorts, including the GRC, the cohort which has been established at Mount Sinai, and we did this work. I did this work when I was at Sinai. There were slightly different characteristics of a cohort. That's not so important, but overall we had about 70,000 people from, deduplication, combining the cohort, try to harmonize the data. So it was a very interesting project, not at the international level, but more at the local. But, New York is like an international setting in a way, so it was fine. And we have published a number of interesting papers. Now we have no time to go into the detail, but we found a number of cancers at increased risk, in particular thyroid, prostate, melanoma, and oropharynx, tonsil. Some of them may be overdiagnosis. There was, however, some work done in using some indicator of WHO exposure, and we did some analysis, try to look at the pattern of risk throughout the years since the accident. But there is one particular aspect I want to mention, and then I will conclude, that as part of the support to the volunteers to the World Trade Center, NIOSH established this nice monitoring and treatment program. There are clinics around the city. One is at NYU, one is in Sinai, and then 3 others, including one at Stony Brook, and this is the one we have at Stony Brook, where eligible responders, depending on some characteristics of exposure, etc., have fully access to screening, diagnostic procedure, and treatment for a number of conditions, and no cost. And look what happened as a consequence of this. We look at cancer survival in those who develop cancer in the WTC cohort, and these are the results, up to 2016. So we should have updated them. Basically, those who were in the program, MMTP, compared to the cancer patients in New York State, same stage, age, blah, blah, had a 40% decrease in mortality after cancer. And the one not included in the monitoring treatment program had exactly the same mortality as New York State. And this was true for all mortality and for cancer-specific mortality. In other words, being part of a well-organized monitoring program helps people surviving from cancer. And many of these people were construction workers, people with relatively poor insurance, conditions or whatever. So it's a good example of how one can improve cancer cancer diagnosis, cancer treatment, especially in a country, in a very rich country like the US. Okay, so I just want to conclude saying that, we know a lot. We know that we have a lot to learn and to study, and yet, we are clearly facing big challenges in terms of funding and opportunities, etc. So I think I really want to finish. I know that this is not the right audience to give this plea, but I want to really say that we need more resources, more support, to train our students, to do our studies, to maintain long-term, follow-up of large established studies. Identification of the causes of cancer and chronic disease was mainly based on epidemiology. There are some examples, but most of the there are about 120 IR group 1 carcinogens. About 95 of them were discovered because of epidemiology. Some were discovered through animal and other studies, but most of that is epidemiology. Okay, and that's what it says here. Okay, what needs to be understood probably requires more complicated and sophisticated, expensive tool. I was just talking to Bob Hyatt during the break. I was in China last week. I visited a center in Hangzhou where they are recruiting a cohort of 1 million people, different components, but overall 1 million, with amazingly strong methodological support, in terms of biobanking, AI. Well, so really, other people are doing this, and it's a shame that we cannot do it, or we can do it at a much lower scale in this country. So it's imperative that US increases investment in population-based medical research. These are some of the people who work with me in the different areas. Carlo Lavecchia from Milan in the trends, Moni Ray in the PFAS work, Julia on the HP, Dr. Malek Sadeh in the IR cohort, and Charlie Hall and Rachel Owens in the WTC work. And these are the two institutions, the oldest still functioning university in the world in Bologna, and one of the most new university in New York State, Stony Brook. Thank you very much.
Thank you. We have time just for a few questions. We'd like to start with the room. So, yes.
A lot of the epidemiological methods. And so one thing I had a question from your years of experiencing looking at cancer prevention is, what do you think now about dose effect? So I know when we think about Dahl and Hill, it's like one of the principles. Do you see a linear effect? But we see that many of these exposures now are not of a linear effect. So what would you say now to epidemiological students who are learning the principles of the foundations of an exposure and an outcome with that principle?
No, very good, very, very good point. So first of all, the Hill criteria or considerations are clearly old, and one needs to interpret them, with a grain of salt, etc. But those response remains, an important consideration. I agree with you that we tend to assume, the linear non-threshold model as a default, but in fact it's probably not the case, and there are threshold relationship, and there are super linear relationships. So the problem is that to distinguish this and to understand really the shape of the dose response, you need good numbers and valid exposure data, big populations and valid exposure data, and oftentimes these are not available in the data we have. So we remain, we give the results according to the linear relationship, but it's just a default. There is necessarily no biological justification for that. I very much like this point, and I think the teaching point here is really that one should not really stick to one only aspect, although it may be difficult, as I said, to distinguish and to identify the right.
First of all, thank you so much. That was such a comprehensive and insightful presentation. I was really intrigued by your mention of the lower incidence of cancer reported in Barshi, Maharashtra. Since I grew up in Maharashtra, and from experience, I know that the use of smokeless tobacco products there through like chewing tobacco products like gutka, canny, and all of those products continue to be a big public health challenge in the area, even though the rates of smoking have gone down. So, in your experience, how would you compare the risk profile of smokeless tobacco, like chewing tobacco products, to traditional cigarettes in the grand scheme of lung cancer incidence?
In the grand scheme of things, oral tobacco is less carcinogenic than
Mhm.
smoking tobacco, although it is carcinogenic, obviously, but it is less. I think in Barshi and these other rural areas, the prevalence is not as high as in some of the urban settings.
Like
That's my
Mumbai.
understanding. Like
Mhm.
Mumbai, clearly. That would be the logical comparison. Yeah. But definitely is one of the causes. So I'm not saying that Barshi is perfect. They do nothing wrong. They have some HPV, so cervical cancer is number one cancer in women, but breast cancer is very, very low.
Mhm.
So they do good things in terms of preventing breast cancer. Oral cancer is number one in men for the very reason you mentioned.
Yeah.
So there is still be some opportunities, but I just use Barsh in this example as a sort of just a comparison because it's so dramatically lower, that one can think it. There are things maybe related to prenatal exposures, perinatal factors, epigenetic. I mean, we have an array of possible hypotheses, but many things that can be done or can happen, to reduce cancer risk.
Thank you. That was a very interesting comparison.
We take one quickly from online. Our online.
Yeah, one of the questions from online was asking if the increase in kidney cancer rates might be there might be a latent effect of high exposure to PFOA and PFOS in the 70s through 90s.
Well, maybe my interpretation is probably related to the small increase we see in other obesity-related cancers. Probably that's probably the most likely. But okay, we can also accept this, although PFAS has really been going down since the 80s, and the increase has been going up to 2010, or roughly speaking. So it would be how much? 30 years latency for kidney cancer. That's possible, but I think PFAS exposure started in the 50s in this country. So we would expect to see some effect of PFAS. If indeed the latency is 30 years, we expect to see some effect in the 80s, but the increase was starting before. Well, I didn't put it in the table, I mean in the graph, but it was starting already before. So it can be one of the contributing factors. We see. Yeah, I'm not saying what I was saying is probably PFAS is not such a strong carcinogen, even for the kidney, that we can appreciate, the effect on population trends. I was not using this trend to say that PFAS is not carcinogenic. I was just saying it's hard to interpret. For asbestos and mesothelioma was an easy one. That was my.
Okay. Thank you so much for a wonderful presentation. And now lunch is available outside the auditorium.
Okay, we're going to get started now with panel 2. Thank you so much.
Good afternoon, everyone. Welcome back. My name is Nicole Bain. I am the Administrative Project Manager for our P50 Community Center that's headquartered here at Columbia, focused on reducing health disparities in chronic diseases. It's led by Mary Beth Terry and several other people who are here today, including our moderator for this second panel, Dr. Ian Cronish. So Dr. Cronish is a general internist and associate professor of medicine here at Columbia. He's one of the PIs of a community center study on medication management among breast cancer patients who have cardiovascular disease. He's also co-director of other centers and conducts impactful research, which we encourage you to read about on the online bio book that's associated with this event. So welcome, Dr. Cronish.
Thanks so much for the introduction. I didn't know I was going to even get an introduction. So just to set the tone for our next panel, will tell you a little bit more about myself. So I am a primary care doctor. I work at it's called Associates of Internal Medicine. It's the practice right across the street and takes care of a lot of patients from this community. And then my other hat is help direct something called the Center for Behavioral Cardiovascular Health, which is a research center that studies health behaviors in patients with cardiovascular disease. And we try to develop interventions to improve health behaviors. And you can imagine that's challenging to do. There's a lot of overlap between all the behavioral factors that underlie cardiovascular disease and cancer, which has a lot to do with how Mary Beth and I have got to know each other. The other part of research that I do is related to hypertension. We already have a lot of treatments and therapies that work for hypertension, but despite that, the metrics on hypertension control, if anything, have gone the wrong direction, or at least are not improving anymore. And it came up in the earlier talk is there's a whole field that's developed called the implementation science, which is all around trying to get doctors to change their behaviors and follow the recommendations that are out there. And if you think it's hard to change patients' behaviors, it's even much harder to change doctors' behaviors. And so I think one of the themes of the next panel is all going to be about thinking about what do we know about the science that primary care doctors, pediatricians, adult doctors should know about. What are the most important things, and what can we do to help them educate their patients and have behavior change in their patients, but also do advocacy around policy, I think is another important piece of the puzzle. A final anecdote is in patient health behavior change, we often try to think about teachable moments, which are good moments for behavior change, which in the context of the research that I do often happens after cardiovascular events or strokes, when you start counseling people about the different medications, but also health behaviors that they can do to help prevent recurrent events. Thinking about environmental health, I think for a lot of us, including myself, one of those teachable or sort of seminal moments, I think, happened when the major forest fires impacted our skies around New York City. I was already interested in environmental studies. I was an environmental studies minor in college, but sort of was really focused around medicine, and it wasn't a huge part of my practice. But I think when that happened, it kind of became very palpable how these factors are impacting all of our health. And around that same time, I started noticing there were some papers being published around pollution and blood pressure and cardiovascular disease, and even some studies looking at indoor air pollution and air filters as being a potential intervention that doctors could potentially prescribe. And there's been some exciting trials coming out showing that air filters actually can meaningfully reduce indoor air pollution and can actually have, in randomized controlled trials, show reductions in blood pressure. So it's just one type of intervention that may come up in the discussion later today. So I want to very briefly introduce our three expert speakers. The first one is Leo Trisande. He is professor of pediatrics, environmental science, and population health. Hopefully I got those correct. At NYU Grossman School of Medicine. He's also the director of the NYU Center for Investigation of Environmental Hazards, and has really been part of some seminal cohort studies which are showing connections between exposures, endocrine disruptors, and other chemicals and pediatric health. We also have Robin Dodson and Laurel Scheider, who are both senior scientists at Silent Spring. Both of them have expertise in exposure science and are going to tell us a lot about some of the research and that they're doing personally, as well as that they're aware of, that is very relevant to what primary care folks like me need to know. So with that, I'm going to pass the mic to Leo to get us started.
Thank you, Ian, for a wonderful introduction. Delighted to be here. I'm going to start with some context of why we don't talk about environmental hazards in healthcare in general. And first of it is just admitting in some ways we're part of the problem. Just to throw a statistic out there, I think it's 14,000 tons of US medical waste annually, of which 20% is plastic. So just to put that out there. And I see some dear friends who are themselves are healthcare providers from across the city and the metropolitan area and beyond. And I think we've been lulled into a bit of it's okay to use chemicals, it's okay to use plastics in healthcare. And I'm not impugning broadly the effects of the things we use. There are some situations that you have to use plastic, for example. You know, I've intubated plenty of babies with plastic endotracheal tubes. I've given tons of inhalation medication for asthmatic kids, and I know that value very well. Gastric feeding tubes for adults and kids who are malnourished or having post-surgical complications or what have you. So just to be really clear, there is a decent amount right now, based on the state of the art, of what we might call essential plastic, if you will. Now, part of the reason I bring this up is there was a time that maybe there wasn't so much plastic being used in healthcare. We just got lulled into the mindset that this is normal, if you will, a new normal. The other phenomenon that I think also explains why in healthcare we're not really attuned to this is the average medical student gets, stats are anywhere from 1 to 4 hours in their entire medical school. I held retractors for cardiac cases multiple times, way longer than that, I'd like to admit. Important role, if it's a small role, in providing care for a patient, but really speaks to the fact that something so fundamental to people's lives is not really being brought into the medical curriculum. Medical boards exams really don't test these exposures. Maybe lead and air pollution are the exception. So it's not, and we've done surveys of pediatricians, I've worked with colleagues who've surveyed obstetricians, and their self-efficacy is great for lead, is much lower. So we're operating in an information vacuum to a large extent. And I think the 3 least favorite words of a healthcare provider are, I don't know. And that means that if you don't know and something comes up, you're like, well, it's okay. Focus on eating, good omega-3 and, maybe less mercury-laden fish. That eating an organic thing or reducing your plastic exposure isn't such a big deal right now. We need more research is needed, is always a good way to go, if you will, in the context of a busy clinical encounter. Mind you, the busy clinical encounter makes it even harder to get these issues across because risk communication takes time, and there's very little time in the, Ian, your visits, are 15, 20 minutes in general. Mine, when I was doing it, were similar length, so there was not a lot of time to work with. And we were also taught what I would say is an old pedagogy. Only the dose makes the thing a poison. The Paracelsian Bible, if you will, is something that still populates its way in toxicology curriculum in some medical schools to this day, when we know there's not a lot of nonlinearity, non-monotonicity for endocrine disrupting chemicals in particular. That there's great science to support it. It's biologically based, mechanistically appropriate. So that's all the apologia that I'll give today. And the science is also telling us not only that there are substantial effects, but there's a way to prevent these exposures. And I'm delighted to be partnering with 2 Silent Spring scientists because Silent Spring arguably put this intervention benefit on the roadmap. I mean, I pretty regularly cite Ruth Ann Rudell et al.'s paper on reductions in phthalate and bisphenol exposures that in 3 days reduced levels by 40% or so, depending on which metabolite. We can debate the context. Probably we need newer studies. Those are really hard studies to conduct. I want to start there. Because in the case of that study, literally there was a dietary substitution event. The food was brought in to reduce the exposure. The containers were reassessed. You had to really take a big holistic view of the household. The other part that's tough about doing intervention studies is they're often predicated on an outcome, generally speaking, like blood pressure or hypertension, and that, or cardiac events or cancer severity, and that's going to take time to sustain an intervention. particularly an intervention where is a ubiquity of environmental insults in environments that we don't fully control. We don't control our workplaces necessarily. Apologies to Columbia for that. But I'd say the same about my home spot. But we're working on that too. But the point being that you're predicated on two from an epidemiological perspective, you're powered on two endpoints. You have to change the exposure, you have to be powered to reduce exposure, and then you have to be powered for the exposure to produce the outcome. So it's just that much painfully hard. And yet, despite all that, relatively small studies, but highly powered, have proven that you can reduce exposures in multiple ways. Be it by dietary interventions, reading the label on cosmetics has done it in a low-income population, filtering air, Ian alluded to, has reduced PFAS during the pandemic. Joe Braun and colleagues showed that phthalate levels in dust dropped as well as PFAS. So pathways can be interrupted to these exposures. And if you can stretch your mind, which I know we all can do here, but in general, the public has a little trouble stretching the mind in that regard. But if you continue these exposures and the reductions in the medium term, you're going to change hormone levels or other intermediate biomarkers, and then you're going to reduce chronic disease risk in the longer view. And yet, we don't communicate these safe and simple steps that I often say don't require the PhD in chemistry and don't have to break the bank. And even just a 60-second elevator pitch kind of touch point can go a heck of a long way. So this is where I start to wrap up and give what I will suggest to anyone that I talk to, if I have just a little bit of time, be they a policymaker, be they a patient I'm seeing in the NYU Langone corridors, or a family that I'm directly counseling. So eating organic works, reduce your pesticide levels in urine in days, similarly to what we're talking about with plastics. We can renegotiate our relationship with plastic. This is an apologia of my own. I appreciate this is a plastic lined cup that I'm about to sip some coffee from. And I seem to have lots of props here today. So no one's drinking them. That's a sign in of itself, Dr. Terry. But when I fly, I bring that stainless steel container. I clear security with it empty, or usually have it in ice. Has anyone noticed that in Europe that actually is not allowed? You can't bring ice through security. That's a different discussion. But suffice it to say that I fill it with water on the other side of security. Et voila, I've got my hydration plan for a couple hour or 6-hour flight. Maybe not to Tokyo, but I'll get pretty far with it. Not microwave or machine dishwashing plastic. I think the recycling number message that we used to give, with 3, 6, and 7 being the most problematic ones, is getting relatively moot more because the customers and the producers themselves are reducing the use of polyvinyl chloride, polystyrene, and the other category that seems to have bisphenol and some bio-based plastics mixed in, which is a hot mess to disentangle. So I've given you that pitch, and I'll close, and I'm happy to elaborate this in the Q&A, because I think I was prompted to talk also about the Global Plastics Treaty. So this is this UN process that began in 2022. It has not achieved what was an overly ambitious outcome of getting a Global Plastics Treaty in 3 years. Paris took 15 years for climate. Who thought 3 years was possible? I don't know. It's an opportunity to look at the entire lifespan of plastic, what I've seen over those 3 years, and I'll talk about the hope going forward. We talked a lot about the policy space interacting with the intervention space and the need for both and, not either or, as part of the solutions. We need and have seen an attention to health in the treaty that is fundamentally revolutionized the discussion in a way such that now the producers of plastic are really getting uneasy about the fact that they have to reduce the chemicals they use in the problematic products, and ideally the plastic production in the first place. And we all know this is coming from fossil fuels as an origin story. So there's that too, from a climate and other perspective. So I've gone over a little bit, and I thank you for the time and look forward to the discussion.
All right. Well, thank you all for being here. My name is Robin Dotson. I am a scientist at Silent Spring Institute. And thank you, Dr. Trasande. You set me right up for talking about what I'll be doing. I am an exposure scientist at Silent Spring Institute, which means that I study how we're exposed to everyday chemicals. Specifically, my research focuses on consumer product chemicals, and I do most of my work indoors, so in home environments. So I want to take a moment to have a kind of a pause and think about when I say what is pollution, what comes to mind? I imagine many of you are thinking about that smokestack spewing air pollution out into the ambient environment. But you may not realize that actually levels of pollutants are typically much higher indoors than they are outdoors. In fact, they can be 10, even 100 times higher indoors. And why is that? Well, that's because there's an intimacy with the sources inside, right? We've got lots of those sources, and we're very, very close to those sources. It's also that the indoor environment is a very protected environment. And so anything that might be persistent is even more so when you put it into the indoor environment. It can last for decades in the indoor environment. So when I'm speaking about environmental exposures, I just want to share a kind of a common environmental health framework that we typically use that's looking at sources to exposure to dose response to some sort of health outcome, right? This is a common environmental health framework that allows us to try to understand kind of what's happening and how these different parts interact. It is really important when we think about the indoor environment to think about potential sources that might be in our homes. So our homes, we spend more than 90% of our time indoors, and the vast majority of that is in our homes. And this is particularly important when we're thinking about younger children who spend even more of their time indoors, as well as older adults. And so in these indoor spaces like our homes, we have a variety of different sources, things like appliances and products that we might use. How do we furnish our homes? Those outdoor air pollutants may make their way indoors, and so that can also be an issue indoors. All of that can then be modified by our behaviors indoors. So it can be modified by our cooking, our appliance usage, for example. It can be modified by our product usage. It can also be modified by the home itself. So what this means is it all makes it a bit more complicated in terms of trying to understand how we can first characterize exposures and then develop intervention strategies. So I've been intentionally kind of vague thinking about talking about pollutants and indoor pollutants, but we are exposed to a soup of chemicals or pollutants indoors. We can have the more traditional pollutants that have already come up, things like PM 2.5 or particulate matter that can be released whenever we basically combust something indoors. You can have lead, which is a very well-known indoor pollutant, of course, affecting childhood development, mostly coming from lead paint, so in older homes. Then we can have things like VOCs, which are those basically the solvents and the combustion products that may be introduced into the home. But those I'd call kind of more traditional pollutants. And then we can have these more consumer product related chemicals, things like phthalates, plastic related chemicals, flame retardants, which are chemicals that are added to things like upholstered furniture. Unfortunately, have been shown to be ineffective in what they're meant to do in that space. Pesticides, PFAS, which we'll hear about in just a moment. Of course, you can have biologicals, as well as the microplastics and antimicrobials. There's a variety of different sources of these chemicals resulting in this kind of soup. Now, when we look at the indoor environment, these chemicals don't necessarily stay put. They certainly do not stay put in the product. They can get into the indoor environment and they can move throughout the indoor space. Many of these chemicals that we are concerned about, things like phthalates, PFAS, pesticides, flame retardants, are considered what are called semi-volatile organic compounds. So that means they can redistribute through the indoor environment. They could be released, say, flame retardant might be released from the furniture, it might volatilize, go into the air, and then it may partition down into household dust. Household dust is an incredible reservoir for contamination inside of the home. So it means that we might design exposure studies that would go and characterize exposures to chemicals inside the home using dust. But we do that because dust is a really important exposure pathway for very young children. Children, just based on their behavior, right, often sit on the ground, playing, putting things up into their mouth, so a lot of hand-mouth behavior. And this can increase their exposure to anything that might be found in dust. Now, in all the work that I've collected hundreds of dust and air samples inside people's homes, I always find phthalates, I always find flame retardants. They're in all of our homes, just as like they're in all of our bodies. But what's really interesting is that when we look for these chemicals, we can see them over a range of concentrations, orders of magnitude. And so the variability is very large, which is actually where the kind of the fun starts. In that I can become a detective. Why are some levels so much higher in some houses? And what are those people doing that are reducing their levels or have much lower levels? So we can start asking those questions. Who's at the higher end and who's at the lower end? And that's where you can start developing intervention studies that are kind of like based in reality, right? So, which is kind of nice because you're already kind of passing that first like feasibility check when you're thinking about intervention studies. So we know that the indoor environment is important. We know it's important for health. And we know that we're exposed to a mixture of chemicals in the indoor space, many of which have common health effects. So what can we do about it? So there are a variety of different things. As I said, I spend a lot of time characterizing exposures, but then I think about what we can do to intervene. And I want to stress, as has been said over and over today, is that these interventions need to happen at multiple levels. They need to happen at the individual level. They need to happen in the marketplace, so we can think about market shifts, market transitions, and then they need to happen at the policy level. None of these can happen in isolation. They're all needed. But we have, at Silent Spring, developed some kind of simple, feasible, realistic kind of tips for addressing some of the common home hazards. On the left here, you'll see there's Joe Braun, which Dr. Trasande mentioned. He and I did a study where we put those Kersey Rosenthal boxes, which became very popular during the pandemic, because they're very effective at reducing airborne COVID exposures. What's also really great is that they can significantly reduce indoor air levels to phthalates and PFAS. What a wonderful co-benefit. And so there's something that it's a fairly modestly priced item. You can build one of these for less than $100 that could have a substantial impact on the indoor air quality in our homes. Those are the kinds of studies that Dr. Trasande had mentioned. These, not necessarily having to bring it all the way to the health effect, but showing a significant decrease in exposure for chemicals that we have a lot of concern about from their health effects. It can be a way to kind of move forward, especially in the absence of these huge, large epidemiological studies. So over on the right are some kind of top tips that we have for a healthy home. There are some of these actually magnets out on the table if anybody's interested. And what I want you to take away from here is that there are some very effective, kind of low-cost, highly feasible things that you can do or recommend to your patients that they can do that might have substantial impact inside their house. So first and foremost, I want to say there are things that you can do that are behavior change, but we should be thinking about source control. We should be thinking about never introducing those chemicals to begin with into the home. So that's things like do not bring in chemical air fresheners, scented candles, things like that. Don't opt for those stain-resistant treatments, which you'll hear more about in terms of PFAS. PFAS lasts for decades outdoors. It's probably even longer indoors. Basically, when you introduce PFAS into a house, it's probably nearly impossible to get rid of it. But there are some behavior change. It's little things like I mentioned before, that children can be highly exposed to chemicals that end up in dust. So if we can just lower the dust levels inside of homes, that can be really effective for multiple pollutants. So that includes things like lead-safe cleaning practices, which is wiping down surfaces with a damp cloth and a mild detergent. It can be using a vacuum with a HEPA filter in it. We have a study in Rochester, New York, where we provided those for just $150 to residents. It can also be things like leaving your shoes at the door. What a simple thing to do that can reduce track-in of metals and lead into the home, especially with children who might be playing on the floor. So with that, I want to, encourage you to kind of pick your favorite, share it, tell others, tell your patients about it, and I look forward to the question and answers.
Great. Good afternoon, everyone. My name is Laurel Shader. I'm a senior scientist at Silent Spring Institute. I appreciate the talks from the previous presenters and from the discussion this morning. Huh? Preventers. Exactly. We're into prevention. The previous presenters and this morning's presenters as well. I've been studying PFAS since 2009 when we first tested for them and found them in drinking water on Cape Cod. My background is in environmental chemistry and engineering, and since then my work has evolved to also focus on diet and consumer products. And now I've learned to call myself an exposure scientist, and I'm even learning about epidemiology as the lead PI for one of the sites within the ATSDR multi-site PFAS health study. And so for today, my goal is to share some information about resources for clinicians, what you need to know about PFAS. Through my research on PFAS, I've had the opportunity to work with a lot of impacted communities. And time and again, we hear from community members that their doctors don't know anything about PFAS, that they're often the ones telling their doctors information. And so a part of what I want to share with you are some resources that we've developed to help with that research translation to clinicians. First thing to know, and in the public health world, I feel like I don't need to say this, but I think for clinicians, it's important to really be clear that there's overwhelming evidence that PFAS can affect our health in many different ways. As we heard a little bit about this morning, IARC has classified PFOA, also known as C8, as a carcinogen and PFOS as a possible carcinogen to humans, with the strongest evidence for testicular and kidney cancer, also evidence for breast, prostate, and other types of cancer. PFAS can suppress the immune system. There's evidence from studies in children in the Faroe Islands and elsewhere that kids with higher exposures to PFAS produce lower antibody levels in response to routine vaccinations. And it's very, when we are looking at epidemiological evidence, it's really important to pair that with toxicological evidence. And there's parallel evidence in laboratory studies showing suppression of T-cell dependent antibody responses. So it gives us confidence that, that the effects that we're seeing in the epidemiological studies do have a biological basis. And there's many other health effects I could talk about, but don't really have time to get into. But for instance, developmental effects, so decreases in birth weight related to higher prenatal PFAS exposures. There's effects on metabolism, blood lipid levels, thyroid, liver function, and many others. So working with PFAS impacted communities, one thing that we often hear from folks is that they want access to PFAS blood testing because they want to know about their own personal exposures and how high those levels are. And so PFAS blood testing is something I will talk about in a minute. But it's one thing that's really important to think about, and this has come up already from some of the previous presentations, are that PFAS exposures come from many sources, and there are some things that we can do to reduce exposures. And I'm not saying that the onus should be on individuals to do all of this on their own, but we do hear from people that they want to take steps, especially in impacted communities. They want to reduce any possible future exposure. But there's things that all of us can do to reduce PFAS exposures. Testing by the CDC has shown that over 99% of people in the US have PFAS in our blood. So all of us are exposed. So drinking water can be a major source of exposure. It's estimated that 200 million Americans have PFAS in our drinking water. Often that's at fairly low levels that are not going to be a dominant source of exposure, but there are many areas where high levels have been present either recently or in the past in drinking water. So in those communities, exposures from drinking water are likely the dominant source of exposure. So as a clinician, and it was mentioned this morning that there are resources for clinicians to find out is they're drinking PFAS in the drinking water in this area, what's being done. EPA has set standards, although some of those are being rolled back and their implementation is being delayed. So there is a patchwork in terms of the availability of data at this point. But that's a first step, is to know whether there's PFAS in the drinking water. For the 44 million Americans who rely on a private well, those well owners are often on their own to monitor their water quality. So when possible, that type of testing can be done for private well owners and is a priority in areas where there are known contamination sources. The good news is that there are home filtration systems such as activated carbon or reverse osmosis that can filter out the PFAS. And for many of these, I'll acknowledge that these are not financially an option necessarily for all patients, but it is an important discussion to have. In areas where drinking water is not thought to be a major source of exposure, in general, we think that food can be a source of exposure as well. In areas with surface water contamination, fish and game can be contaminated by PFAS. So as a clinician, you can look for local fish or game consumption advisories. In the general population, we do see that people who eat more fish and shellfish tend to have higher levels of PFAS, but it's a little bit different, I would say, than methylmercury, where the trends are very clear and we have a lot more certainty about which types of fish have high methylmercury. So I feel like it's kind of an emerging area for us to really understand what types of fish are high in which types of PFAS. Food packaging also has been a source of PFAS exposure. FDA has changed some of the approvals, so this may be less important moving forward, but we've typically told people to avoid microwave popcorn and other types of fast food packaging that may be treated with PFAS for grease proofing. And then we've talked earlier in this morning's session as well about cookware, when possible, to avoid Teflon-coated pans and opting for other options like cast iron or stainless steel, some which may be expensive, but there are some less expensive options as well that are PFAS-free. And then thinking about consumer products, there are a wide range of consumer products that contain PFAS. Some we can identify, so a Gore-Tex jacket, Scotchgard coated textiles, Oral-B Glide dental floss, you may not know, is made out of Teflon, but there can be some surprises as well. For instance, waterproof mascara. So many products contain PFAS. So we do have some options, and Robin mentioned some of the tips that we provide from Silent Spring Institute. You can avoid products with stain-resistant coatings or waterproof properties. Selecting dental floss or cosmetics don't contain PFAS. And I've learned from Robin, keep dust levels low. So now is the time that I'm going to talk about PFAS blood tests. So knowing about individual exposure is something that we hear from many impacted community members. It helps them understand the extent of their own exposures. They can monitor over time to see if their exposure mitigation is successful. It can inform clinical follow-up and medical screening, as I'll talk about. And while there might be a tendency to not want to worry people, because it is alarming to know you have PFAS in your body, time and again we hear from impacted community members that ignorance is not bliss and that having that information is something they're seeking. It's important to be aware of the limitations, though. So current PFAS blood tests only capture maybe 7 or 16 PFAS compounds. We know there are many others that we're exposed to. And so it's important to know we're not capturing the whole PFAS exposure scenario. Levels of PFAS can change in blood over time. So someone might not have low levels now, but maybe had high exposures in the past. It can be very difficult to relate levels of PFAS in blood to an individual's disease risk or to a health condition that they're experiencing. And the cost can be prohibitive as well. Insurance often doesn't cover the cost for these tests. But clinicians should know that it is possible to order PFAS blood tests, for instance, through Quest. And for patients, they can also order it on their own through Quest Health or through a home-based test. And we have information about this on our PFAS exchange, which I'll talk about in a minute, with information about PFAS blood tests. As a clinician, you might wonder, okay, if I order this test, what am I going to do with those results? What does this mean for people's health? And to address those concerns, the National Academies issued a groundbreaking report in 2022, and one of their key conclusions was that clinicians should offer PFAS blood testing to people who've had high exposures and are seeking this type of testing. They did a thorough review of epidemiological and toxicological research and came up with categories with medical screening and screening tests for patients depending on their level of exposure. I'd say it's kind of a first step towards linking PFAS blood levels and certain types of screenings. Some of these are within standard of care, but some of them are more prioritized for health effects likely linked to PFAS exposures. So to help clinicians and really anyone learn about PFAS, our team has developed the PFAS Exchange. I would encourage you to check it out. We launched a new version last week. This was originally developed for people in impacted communities to empower and educate themselves about PFAS. We have a page now specifically devoted to clinicians. On the page, we have a CME course all about PFAS where you can get credit through Michigan State University. We have medical screening guidance documents. We have a pair of documents, one that is patient-facing and one that is clinician-facing. Our team of public health researchers and community members partnered with clinicians to develop sets of medical guidance, so the types of screenings you might consider for people who've had high exposures. We have information about PFAS blood testing, fact sheets about health effects and exposure, and the part that we're, I think, most proud of is our data interpretation tool. So when you get the results of a blood test or a water test, you get a lot of chemical names that look almost like the word PFAS. It's PFOS or PFOA. It can be very difficult to know how to interpret those results. So we have a tool, and it's built with our Silent Spring team's expertise in report back. So the tool allows users to type in results of water and blood tests, and you'll get graphs and headlines to help you interpret those results, compares you to the general population and to any relevant guidelines. So I know I'm over here, but I just wanted to end with a case study. So this is Sandy Winstelt, a community member from Michigan. Her private well had tens of thousands of parts per trillion of PFAS. For reference, the EPA standards are single-digit parts per trillion. She lost her husband to liver cancer, which she later thought was linked to their PFAS exposure. And when she started to develop a hoarse voice, she went to her doctor. And because he knew her blood levels were extremely high and he knew about the effects of PFAS, he tested her for thyroid cancer, which he said he would not have really looked for given her symptoms. But because he knew about her exposures and her blood test results, he thought of that more quickly and was able to diagnose it in a way that likely led to a better outcome for her. And so her example is extreme in some ways because her exposures were so high, but that's kind of the model that we see, that having information about exposures and awareness of PFAS health effects can improve clinical care. So thank you.
Okay, so we'll ask the three experts to come sit here, and I will help moderate questions. Is that someone checking online questions as well? Yeah, great. So I'll just get started a little bit so other people can start thinking of their questions too. I'll just start with the first question, which is, what do you think a primary care doctor, what would be like the top thing that they should have on their ready to sort of screen for with their patients? Assuming that they have a little bit extra time in a visit or in a certain context.
Okay. So because I knew who was following me, I didn't talk about PFAS. So I had it I had it easier to fill my time a different way. But we were talking about this during your presentation, Laurel, that to me, this is a watershed report in that it's the first test since lead exposure in kids that we should be routinely offering, but we're not. 150 million Americans should be getting their PFAS serum tested. Now, if you live in the 5 boroughs in New York City, you are probably okay because of an infamous land grab of the Croton and related Delaware reservoirs that lead to, heavily guarded by NYPD, mind you. It's one of the weirdest things you'd ever see, is you see all these NYPD folks up in the upper counties, but that's their joint, so they get to hang out near it. And that means that we don't get PFAS in New York City from the water supply primarily. Now, we could get it through the tubing that comes in, just like you can get lead through the tubing that's in the the last half mile or whatever, the pipes in the home, essentially, where there could be exposure through various pathways. But it's prime time. New Hampshire is the only state that I think requires insurance coverage for PFAS clinical testing. If I were a New York State legislator, I would be pushing that as a thing among other states across the country, because as the NAS report outlined, there are steps you can take based upon the PFAS results. And there's an algorithm on the web that you can model PFAS exposure based upon water levels when they're available. So and if you use the Silent Spring module or the equivalent, you can go all the way to not having to stress the clinician out about interpreting the results. The steps are pretty clear. You just play the playbook. You don't even have to open Harrison's to do that. You can actually take steps and follow up and maybe advise interventions like getting the nonstick cooking out, maybe not using so much oil and water resistant clothing, or swapping that out, looking at dust, not wearing your shoes in the home, filtering the air, all that stuff that we know works from research like these great people next to me do on either side. I'll stop there.
How much does it cost if you want to pay out of pocket?
Well, what is it, a couple hundred right now is the problem? So I'm a believer in volume of shaping price. So if you have a volume of testing that's required and then you get insurance coverage, there's probably a meet in the middle where that price point comes down. So I'm admitting openly that if you don't have insurance to cover the test, this is a little bit of an issue, or a big issue, maybe I should just say. So that's a limitation, but much like I pushed people to eat organic perhaps before the price points had come down, we have to do the same thing here, because from my perspective, it's a crime that we're not measuring, because if you don't measure, you don't see. These are invisible exposures to begin with. The only visibility is the clinical test. I've come a long way in thinking about this. I used to say, well, don't test this, you'll scare people about that. I don't think we're that far off from phthalates and bisphenols joining the scene at some point. It's going to take probably another National Academy of Sciences report like that to drive it. But I don't see why there's a difference, by the way, between PFAS and those other exposures, flame retardants. We can throw in a few others to boot, that are all modifiable. They may not be modifiable all in the same time scale, but they would produce potential clinical benefit.
Give the audience a chance to jump in.
This is actually a question from a previous panel that we didn't ask, but it is about PFAS. They're asking about studies of firefighters exposed to AFFF firefighting foam containing PFAS and associated risks of testicular and bladder cancer. If you could speak about the firefighter risks.
Sure, I'll take that one. And I would just to add to what you're saying, I think it is critically important to offer PFAS blood testing, especially in communities with high exposures. But I don't think we can take our eye off the ball for other things, like PFAS are getting so much attention now. But in some communities, a big concern is still lead service lines or the types of chemicals Robin talked about. So, and it's hard to keep many things in our mind at once. But I think the PFAS screening is important. But I think it's also important to recognize many other types of pollutants are still an issue. To the question about firefighters, there is evidence of elevated exposures among firefighters that can come from a couple of different pathways. So one is a certain type of firefighting foam called AFFF. This is not the type of foam you use for a structural fire or a forest fire, but it is used for liquid fuel fires, so training or fighting, say if an airplane catches on fire, so or an oil truck rolls over. So at military bases, airports, and other fire training areas, these are often show up in groundwater or surface water, but it's also of concern to the firefighters who are handling those foams. And in the past, they used to be used at community events, like fun things for kids to be in the foam before we knew all that we know now. So that's one concern. And then another, that foam is not typically used, but that can be a source of exposure. And then a more broad concern is the firefighter gear, which contains a layer of it's heat. The PFAS make products heat resistant and resist water, and so they're great for protective gear, but for firefighters. But the concern is that can lead to elevated exposures because firefighters have their gear on all the time and in their firehouses. And just last year, Massachusetts and Connecticut became the first 2 states to ban the use of PFAS in firefighter gear. And I did want to emphasize, this came up a little bit this morning, that we may not see a lot of action at the federal level on limiting chemical exposures in the near future. But there's a lot that states can do, and some states have banned PFAS in food packaging, acting well ahead of the FDA. Some states had drinking water standards in place before the EPA acted. And so some states are tackling different parts of the PFAS issue, and this comes up for other types of chemicals as well, for instance, California and flame retardants. So I think that that's a way to engage, and there are opportunities to get involved with legislation at the state level, and I think legislators do really listen to MDs, the other type of doctor that I'm not. So I think it's important to get involved.
Is there an audience question?
Hi, thank you. This has been such an exciting panel. I'm Elizabeth Cohen. Thank you so much for this. I'm going to ask a question that I'm channeling kind of the world right now. Please tell us more or better about scented candles. We are so sorry to hear. We are so sorry to hear this, and like a bunch of hearts in the back row dropped. So can you help us have better smelling houses while still being safe?
Well, where to begin? So there's a couple of things, right? So scented candles, well, they're combusting something, so they can release things like particles. Also, what is the wick made of? Things like that. So there's a combustion element there. But there's also the scent element, and in that, there's a lot of synthetic either fragrances. There can also be phthalates, which are incredible at holding scents, and so it can release lots of different pollutants into the indoor environment when burning those scented candles. But I would suggest that there might be other ways to have nice smelling homes. If it's feasible for you, ventilate is one way to do it. Of course, you can just use natural things, things like orange slices on your, on a pot kind of thing on your stove. One thing that actually I have heard and be interested in terms of thinking about a behavior that's actually been a little concerning in terms of people trying to scent their homes actually by using, trying to boil or simmer Fabuloso in their house. It can be a common thing in some communities, and so that raises a lot of concerns, and in fact some studies have seen like very high levels of phthalates, and it has been linked to the fact that people are kind of just putting a little bit of Fabuloso on that back burner. No Fabuloso, exactly.
So I want to build on this question about candles. Robin, you mentioned that it's the combustion of whatever. Have you seen those heating lamps for candles where it's just melting the wax? So there's no combustion at all. So I'm asking, maybe we buy soy candles that only use essential oils and we heat it instead of burning it. We love candles. So I'm trying to find a solution, right? Like
You're asking for a friend. Yeah.
I mean, that's a behavior change. Would that work?
I mean, yes, it's a step in the right direction, exactly. I mean, and that's the thing with a lot of these intervention points is that I do think that we do not need to whole hog jump in, suddenly have, a sparkling clean home kind of thing. You come into my house, I do this for a living, and I don't follow every single one of those principles, right? Every little step help. So if you can move towards more, soy-based candles with natural wicks and things like that, or other things, that's a great step in the right direction. And I think we can encourage folks to do that because it's every little thing that might help. You don't know what will be the thing, too. That's the ultimate.
Hi, I have a question regarding the household products. Especially in my household, we regularly use aluminum foils for wrapping the lunch boxes for kids or the tea bags, that I drink tea every day. So I'm just worried about microplastics or anything known about in the community with research perspective that we should be avoiding, especially aluminum foils and the tea bags. Thank you.
Um, okay, so let's talk about microplastics and nanoplastics. There is as much as we don't know as we know. They could be the toxic drug delivery systems for the chemicals that we've been talking about all day, or they could be the human wrecking balls in tissue. I don't know. I mean, sure, I've read the New England Journal of Medicine study that showed a 4-fold increase in heart attack, stroke, and death as a composite outcome in relationship to polyethylene and polyvinyl chloride. And by the way, that matches another study we had done looking longitudinally at phthalates and cardiovascular mortality. So actually, ironically, talk about Bradford Hill criteria, there's actually 2 different exposure methods giving you the same readout, which to me is super compelling. It's not really talked about, but the point about micro nanoplastics is they're probably not good is the answer, and probably there are steps we can take to prevent it. So you talked about tea. Last I checked, loose leaf tea you can put in the, if you're not on the move, and again, don't let the perfect be the enemy of the good is I think the other thing we need to just get out there. If you're in home and you can avoid using, a plastic tea bag, go for it. Use the loose leaf, put it in the stainless thing. Last I checked, I'm a coffee drinker myself, so this is a little bit out of my lane. But now fortunately we don't have microplastics as exfoliants in many dermatological products as well. So it speaks to progress. I don't think we fully understand the scope of the impacts, but again, I think we're taking steps to reduce them. And if there are no direct positive benefits, what's to lose in terms of reducing the exposure to the potentially negative things?
Dental floss should we be recommending to our patients if it comes up?
Sure. So high level message, like don't stop flossing. And often I give talks and go through the whole long list of all the things that contain PFAS, and Oral B Glide is the one people are like, not my dental floss. So when it's that flat ribbony, that is the type that has Teflon. That is Teflon. It's not coated with Teflon. It just is Teflon. So don't. Yeah, so in a previous study that we conducted, Oral B Glide and sort of the generic blends that say they are like Oral B Glide, they're made with Teflon. And so from a previous Silent Spring study, we found that people who reported using Oral B Glide had higher levels of certain PFAS in their blood. So wax, so wax is probably the most easy to find. If you're at Whole Foods, maybe there's silk or other types. But I'd say as long as it's not that flat ribbony type, and go for something like waxed is good.
Hi, I am Parisa Charanafar. I'm with Columbia Cancer Center and also Department of Epidemiology. Great panel. And it's sort of going back to what Liz was mentioning and Adena about the candles. And yesterday, we also had a symposium for one of the social capital centers. And we had a talk on commercial determinants of health. And one of the key takeaway that I thought, I never thought about it in my research or when we give public health advice or strategies, was that how good companies, commercial companies, for example, tobacco companies, et cetera, are good at making things pleasurable, right, for people. So like if you take away the fat, or if they can do fat-free or low fat, but then they add something to it, food coloring or something that gives them pleasure. Same thing with candles, right? Like the idea of not just saying, like what can we replace it with that at least is better, that's also pleasurable, that gives people pleasure. Because I think we miss that sometimes. I mean, I have missed that in my kind of thinking about things, but is there something to make your house smell good and feel cozy, especially as the holiday season comes. That's not just like through scented candles, etc. So just a thought, really not a question, but I'm sure.
Yeah, no, I mean, I to each his own on there. I mean, if the holidays come and you bake that apple pie, I mean, I just think that there's other things to do, right? That or an organic apple pie. So there are like little steps there. I mean, I do think it's fascinating. I think air freshener use and scented candles and all that is fascinating. We done in our work in our residential exposure studies, we ask people, like we observe or that they might use air fresheners, and we ask them why, and a lot of it is just they like that. It's like they associate it with clean and things like that. That's going to be really hard to change as a behavior. And in fact, in some of our work where we have done education around it, it's one of the hardest things to move. People will start using a doormat. People might even start taking their shoes off, but they don't touch my candles. And it's an issue. And so I think we need to just come up with kind of maybe better messaging. There's maybe kind of what is that thing? I think we're still figuring it out that will get people. Right. So maybe it's tapping into that a little bit. And I would love to talk to kind of behavior scientists about what is that thing. Yeah.
Hi. Thank you all so much for being here today and taking the time to speak to us. It's been great. Going to a point that you mentioned briefly about boiling the fabulosa, you touched on a key word for me, which was like certain communities. And, when thinking about informing policy as like a public health issue, I think that there's like a lot of overlap with environmental justice issues as well. And I was wondering if you could maybe speak to how research can inform, public health topics as well as like justice topics as well.
So in these times, I want to emphasize you can use language that's equally effective by just communicating the plain darn facts. I would use some more colorful language, but I know I'm being streamed. Policy is a great leveler, and these exposures are unfair. Last I checked, fair is an okay word to use. And so if we use fundamental issues of fairness, you cover all sorts of populations that have disproportionate exposure. I'm not saying I'm against using the words that we have been using for years, and I abide by them, but the principles are the same. If you really talk to people about fairness, I don't think you're going to get a problem there. And these interventions have worked for direct benefit across all sorts of backgrounds. So those are just my thoughts. And I if I can put in a little bit of it, and this is maybe self-advertising, so I apologize. These are costly too. So just in terms of thinking and adapting messages, and this is why I wanted to bring it in, is thinking and adapting messages to the current age. We're talking about endocrine disrupting chemicals costing the US $340 billion a year. 50,000 Americans dying from heart disease due to phthalate exposure. 5 to 10% of prematurity. Those are, I think, potent messages that can run across the gamut, and I think can get us where we need to go, while still sharing the same true north that we're talking about. So I hope that's helpful.
Yeah. So I encourage you to check out actually one of the first visuals that I used in my talk was this from a paper called "Moving Environmental Justice Indoors." And it was this idea that if we can tackle like housing broadly, it can really address multiple issues. It can address issues around safety. It can address issues even around, injuries, things like that. But it also can address chemical exposures. And so I think thinking broadly about some of those things that we can do at a systems level that could have all these co-benefits that we're not necessarily realizing. I'm doing some work right now in Rochester, New York, where we're looking at homes that are going through lead hazard control. So these are low-income homes by definition, and they have children in them. And we are seeing significant reductions in lead, as there should be, because HUD is spending millions of dollars every year across the country to do this. But what if it's also reducing exposure to other chemicals inside the house? And so there's something where we could leverage a system that might be kind of maybe not a hot topic right now, but more just kind of like a, hey, we're going in already and doing this work. Could we just leverage that in a different, just do a couple of things? A couple of things that we've actually found in that study is, in addition to the work that's being done for lead, what if we just gave everybody in a study like that a new furnace filter and taught them how to change their furnace filter? And that can be, it's like a $30 thing where you can just go in and it can have significant improvements to their indoor air quality. You're going in for lead for something else, and you can have like a really a big impact by just a $30 investment. So I think we need to think creatively about existing structures or existing systems that we could leverage to help address, some place in some communities where, we just need a little bit more assistance, or kind of, just to make it a little bit more feasible, I guess, to address those issues. Yeah.
And I'll just mention as well, since my work originally focused on water quality, that we are also increasingly thinking about disparities in exposures to drinking water contaminants. And I think after the Flint, Michigan crisis and more recent examples like Jackson, Mississippi, it's become more apparent that there are important disparities in drinking water quality. And some of that pertains to things like lead, which we've regulated for a long time. And so there's still work to be done along those lines. But when we think about emerging contaminants as well, like PFAS, we did a study this year where we did find disparities in that water systems serving higher proportions of Hispanic and Black residents had higher PFAS in their drinking water. And some of that might come down to enforcement, but some of it's more proximity to pollution, or just a community's ability to put in place treatment, or to have their source waters come from a more pristine area like New York City. We did the same thing in Boston. And it's interesting because there's sort of different geographical scales. So if you think within, like, I live in Boston, so the same thing in New York City, like everyone has the same water, pretty much. There might be some differences in lead or things that come from the pipes, but everyone has the same water, whereas like, air pollution exposures are radically different depending where in the city you are. So there's kind of different geographic scales where these disparities matter. And I think it does just point to the need for federal regulation, that we can't have this patchwork, because before the EPA set PFAS drinking water standards, some states had regulations and some didn't, and they tended to be higher income states. So that there are kind of disparities. It's great that states can take the initiative and move forward, and that's important to drive things, but we can't just only stop there. We really need to make sure we're protecting everyone.
Can I ask one question? Sorry, I think we're out of time. I want to be respectful. I just have a quick question. And Dr. Buffetta showed a slide with the PFAS, which I'm learning tons from this. Like, it's not something that I was taught to ask my patients about. But he did show one slide with this dramatic reduction in PFAS levels that looked like this major success story. And so I just was wondering if anyone could comment on, why we need to be so worried about this today.
I have thoughts. So I think it is an example of policy change leading to reduced exposure. So yeah, over that period of time, those PFAS that he showed on the graph, the levels in people's blood have gone down because industry stopped manufacturing them, at least here in the US. They are extremely persistent, so those it wasn't an official ban, but phase outs happened decades ago. These chemicals are still prevalent in people's bodies. They're still detected in everyone's bodies, just at lower levels. What that graph doesn't show are other PFAS. So we haven't talked about regrettable substitution, but we phase out one thing that we know is bad and substitute it with something chemically similar that we haven't really studied yet. And often it has the same health concerns. This happens with BPA being swapped out for other bisphenols that have the same estrogenic properties. So the same thing is kind of happening with PFAS, where we're phasing out those. You can see the levels going down, but we don't have good data yet on the increasing exposures to other PFAS. And that's the national average. And so some communities are lower than that, and some communities are much higher. So that still remains a huge concern.
Bravo, thank you so much.
If I could just chime in really quick. So NAS reviewed in that report that you cited testis and kidney cancer, and they slam dunk accepted that the evidence. Just to be very clear, I think that to say that there was a lack of exposure response, I wish I had the chance for a Q&A. I have tons of respect for Dr. Buffetta, by the way. We're very clear about that. But you know, there's more evidence there than meets the proverbial eye. And I would emphasize that, you know, Sir Austin Bradford Hill said that you didn't have to have perfect evidence. You didn't need 100% causality to act. It's actually variable, the level of causal evidence you really need, depending upon what the stakes are of the particular action. So context really matters in the space of what's involved in changing what you're proposing to change, who are the potential losers, who are the potential winners, and what are the potential stakes involved.
Why don't we give a hand to all the speakers? Thank you so much for coming today. We're taking like a 5-10 minute break till the next panel. Okay.
Hi, everyone. I'm Dr. Christelle Wilfrank. I work with the Community Outreach and Engagement Office here at Columbia's Cancer Center, and I have the privilege of introducing Dr. Adena Llanos, who is a geneticist, cancer and molecular epidemiologist, and health equity scholar whose research bridges molecular biology and population health to illuminate the complex pathways linking social inequities and biological mechanisms of disease. She's published the largest study linking hair care products to cancer risk, and through her research, leadership, and service, Dr. Llanos is committed to advancing a more equitable future in which all people have the opportunity to thrive. So, Dr. Llanos. Thanks for that introduction, and thanks for the opportunity to serve as moderator for panel 3 on how cancer care providers can address patient concerns. I'll say this is the best session, so thank you guys for staying. Honestly, I mean, this entire program has been amazing. I was just joking. But I am delighted to, welcome you to panel 3. So when we talk about cancer prevention, we often focus on genetics, behavior, or access to care. And today we've broadened the lens, right? And so we've been considering how environments where people live, work, age, quietly shape cancer risk and survivorship. So in this session, we'll have 3 incredible speakers who will share different but deeply connected perspectives. So we'll start with Mary Beth Hans, a physician assistant who works with women at elevated risk for breast cancer. Mary Beth brings a deep, practical, and patient-centered approach to this conversation. She'll share how she integrates environmental health counseling into her clinical practice using tools like Detox Me, which we heard about a little bit earlier, and the Silent Spring Institute's Healthy Home Tips to help women make small, achievable steps towards reducing their environmental chemical exposures. Then we'll hear a breast cancer survivor's perspective from Eileen Fuentes, who is a healthcare leader and patient advocate who has dedicated her career to advancing patient-centered cancer care and achieving health equity. And our third speaker will be Dr. I'm going to say this right, Yeguang Wei. All right. He is an assistant professor at the Icahn School of Medicine at Mount Sinai. So Dr. Wei will present his research showing how air pollution contributes to lung cancer risk among older adults. His team uses large national data sets like Medicare and SEER Medicare to understand how even modest increases in fine particulate matter can lead to significant disease burden. So after these 3 presentations, we'll have a discussion exploring how to communicate environmental health risk and how to do that clearly. And really bring it into clinical care and foster collaborations that translate research into prevention and action and policy. So with that, Mary Beth.
Hey, good afternoon, and thank you for having me. I was asked to speak a little bit today about the perspectives from a clinician who is actually relatively new at incorporating environmental risk factors into the conversation about risk around breast cancer. And I will say that's quite the statement because I've been in this field for about 30 years. And that means that I have, I've done all the things. I've gone to all the conferences, my CMEs, I had incredible mentors. And yet this was nothing that was really ever brought to my attention during all that time. So despite all of that experience, it was a patient that brought this to my attention during one of our meetings. She had a connection to Silent Spring, and she asked me what I knew about environmental risk factors, and I was honest, and I said, I really don't know much. And she suggested that I look into it. And so like I do with everything patients suggest to me, I've always done this. I like to know what my patients are reading, where they're getting their information. I did. I looked up Silent Spring, and I was immediately taken by the volume of resources that are available there, and was frankly a little embarrassed that I wasn't aware of it. So that caused me to reach out to Silent Spring, and they were gracious enough to come to our program and do a journal club for our clinicians, which was very helpful to me. It helped sort of open the conversation about trying to do this a little bit more purposefully. That led to them agreeing to speak at a couple of our patient forums where we run a forum for women who are at elevated risk, presenting topics on all types of things that are of interest to them. And so they came and presented to that group. And then most importantly, created this incredible patient education materials for us to use in the clinic. I don't know if is it on here or? Yeah, so this is the one that they created for us and is now available on the website as well. And so for somebody who was a little bit, apprehensive about bringing up the topic, as was mentioned previously, a lot of clinicians don't like to ask questions that they're not going to be prepared to answer, fully, and so we tend to just not bring it up or kind of glaze over it if a patient brings it up. And so having these physically present in the clinic really helped to, start the conversation. Again, it is a little bit reactive, the conversation initially, where I sort of depended on the patient to ask me about it, and then I felt comfortable talking about it a little bit more. And so one of my goals is to sort of move this now to a more intentional, proactive conversation. I'm very interested in the work that's being done on how to, properly include this in your review of systems and in your notes. So that's something I'm going to be, working towards next. And I will say I am trying now to, I'm continuing to educate myself. Coming here today was hugely beneficial. If we can get this more into the typical, conversation about review of systems and modifiable risk factors, we can talk all day long about alcohol and smoking and exercise and obesity, but we don't say anything about environmental risk factors. So being able to now have the tools where if somebody asks another question about it, I know where to go and get the information. And I hope to be for my colleagues what my patient was for me, and that now the talks that I give for community members and for clinician groups, I now actually do include slides on environmental risk factors and links to Silent Spring. And several clinicians have come up to me after some of these meetings and said, oh, I didn't know anything about that. And so I think it is sort of a pay it forward kind of responsibility for those of us who have woken up and are aware of this now. And so I just would like to say to anybody who's starting out in this or thinking about doing this, that there's a lot of resources out there for you to help your patients and to educate yourself, to not be afraid to start. start small. These action tips are really very digestible and easy for patients to work at, and they like to be involved in their care. They like to sort of take active steps themselves to reducing their risk. And I will just say it's not the worst thing if you don't know the answer to a question somebody is asking you. They very much appreciate when I say, oh, that's interesting. I don't know. Let me find out. As long as you really do go and find out and you do look it up and you talk to the people who will be able to help you and get back to that individual. So I think just not being afraid to get started with it is the key thing. Surround yourself with the people who have the information, who can help you, and avail yourself of all of the resources that are available to you. And that's, again, the 10 tips that I have in my clinic as well. So I suggest people take a look at those when they leave. That's all I got.
I have to have my notes so I stay on track. So this is interesting because I took a bunch of those and I've never heard of Silent Spring. So I'm so happy to be here because I'm going to harass my family thanks to you. So I am a breast cancer survivor. I was diagnosed 17 years ago. And so, that's an interesting place to be when you're a hospital administrator, specifically director of HR and in pathology where cancers are diagnosed. And on top of that, I'm a patient advocate. I used to be on the steering committee for the NCI. I'm part of the Health Equity Collective. That's a national organization, SWOG Cancer Research, and the Society for Integrative Oncology. So I have my hands in everything. And it's interesting because, this is just gives you a unique perspective about everything, that you do, because everything that you touches a different part of your life. And I actually walked here from my house, so I walk to work. I work across the street, and so community for me is really everything. And it's interesting because policy, like thinking of the workforce and their contribution, and then the systems level access to all these things, and these conversations don't happen at all. I used to oversee the patient navigation program for breast and GYN oncology, and it was very rare that these things came up. And because I'm a hospital administrator, I understand that there's 15 minutes to do absolutely everything, and it doesn't give you enough time. And so, for me, it's really like collaborative. My whole world is collaborative. I live in a lot of different worlds, but I think that when we're thinking about patients, we bring the experience. When we're thinking about providers, they bring the clinical expertise. The communities bring the cultural understanding. And, all of this, it's hard enough to understand medical jargon. It's even harder to understand 26-letter words when we're talking about chemicals, and especially when you have to translate that to even another language. And this community is highly immigrant. They don't even understand many of the things that are being said to them in English. I think that I just keep my head is going a million miles a minute as you guys are talking, because I do a lot of the right things. I thought I'm struggling with the candle piece, and and I don't use candles, but I do use essential oils with diffusers, and I hope that's okay. But also I sit in the room with policymakers and thinking about how we communicate with all communities, even those that don't have a good grasp of the English language. And so, community engagement is really a two-part conversation. And so many times I feel that we're being spoken at, not spoken to. And, and that's why there's all these trust issues within the community and the doctors that serve them that have all these good intentions. And I know I'm in a room full of like what I call my people, the people who really care, the people that are on the front lines. And, but it still does feel that way. A lot of it does feel performative when you're like out in the world and you're seeing how people are being spoken to, as if they don't know, and maybe they don't speak the language, but so many of these people are professionals. So many of these people are the ones, I used to run a wellness program here for about 7 years. And every single time I learned so much more when I walked out of there, because so many of the patients have so many of their old customs that they're bringing into these spaces, and no one really asks. And if you ask, they're like, wait, that's alternative. We can't have that conversation. And that's why, being one of, I sit on I'm one of the co-chairs for the Society of Integrative Oncology, and bringing back some of these old systems and some of these oral stories that I think communities of color bring are so vital to these conversations, and they just never come up. And again, and I get it because of my job that there's only 15 minutes to do a lot. So so I just think when we're talking about language access, that's really, really important. It's really important for trust building. It's really important to get community informed research. And a lot of that happens here. I know that because I work here at Columbia, but there just isn't enough enough of it. And there's also this weaponization of all of this right now. And I think the good part about it is that I think people are pushing back, and if things were status quo, people wouldn't probably be doing that. And I don't know, I can't think of a better time to start having these conversations because, you know, um, I'll stop there because then I'll get in trouble. So I'll just let's see what the notes say. And so, so what is the benefit to the providers and the systems that support the providers and the clinicians that work here? I mean, I think cultural competence can deepen empathy, and that's really important in order to establish a lifelong relationship. I mean, I'm 17 years out, so I get it. Also, researchers, they get better and more actionable data that they can use. I think coming to these conferences for now 17 years, I just hear the same things over and over, but I'm not seeing so much of the action. And I don't think it's because anyone is bad intentioned, but it's just so much of the same rhetoric and very little actionable steps. And hospitals are also places where patients would need to trust you. They need to follow up. They need to understand the outcome. So I heard it earlier where we were saying, like, when you say I'll circle back, the circle never closes, and so sometimes it just kind of stays like a crescent. And so just making sure that we get back to that, I think that's really important. And inclusive systems where they create healthier, more resilient healthcare teams. I remember I was a part of a team, like living in the community, being a person, from the Dominican Republic, like everyone in this community mostly used to be in the past. It made it really easy to have conversations. I think, just when we're talking about food, I remember being at a conference and they said that you should eat a Mediterranean diet. And one of the ladies was like, where is that even, And so you're telling people to stop being who they are. And so that, and I think if there wasn't so much bias in the research where the people that are conducting the studies are thinking about their own cuisines and their own customs, then, like at least my entire part of the community is being left out of that conversation. And I'm happy to say that at a conference that I was at Boston last week at the Harvard Medical School, we brought, the benefits of bachata dancing to the cancer community, and that was really nice. And then just in general, listening more intentionally, including more diverse voices, acting consistently, and then just remember that nothing about us should be without us, because we should always be part of that conversation. And if there's a way to have like a community advisory board for anything, and making sure that those things are compensated, because again, when we're talking about these are communities that are under-resourced in so many ways. And so it's important that if we are extracting from them, and many of the people, at least in this community, are being pushed out, then that at least if they're contributing their voice, then they should be compensated for it. And so I think that's it.
Hi everyone, my name is Jiaguang Wei, and thank you for staying with us. So I'm going to talk a little bit about our recent work on air pollution and lung cancer. We'll focus on older adults as they are the most affected patient group by lung cancer. Lung cancer is a leading cause of cancer deaths in the US. It accounts for 1 in 5 cancer deaths. It primarily affects older adults. About 68% of patients are diagnosed, and 75% of the deaths occurred after age 65 years. Here are some leading environmental risk factors. Smoking remains the dominant environmental risk factor for lung cancer. We have now recognized air pollution as that plays a critical role. In 2013, the International Agency for Research on Cancer classified air pollution as a group 1 carcinogen. One of the most famous air pollutant you may heard about is PM2.5. Is there a pointer? All right. It is PM2.5 is really a complex mixture of various components, and it is tiny, tiny particles floating in the air. So once inhaled, it can pass through the lungs, circulate throughout our body. That's how it causes various problems, including lung cancer. Another environmental risk factor is radon. It is a naturally generated gas, usually accumulated in the basement or lower levels of home. But today we're talking about the air pollution. Let's talk about some recent evidence. So there has been a lot of large-scale evidence on air pollution and lung cancer incidence. That's why IRC classified, air pollution as a group 1 carcinogen. The study present here represent one of the most recent evidence. In this study, we did a national analysis among the national Medicare cohort aged over 65 years. We used ambient or ground level air pollution estimates and link them to the residential zip code as their proxy exposure measures. We included over 12 million individuals, and we found that long-term exposure to PM2.5 and NO2 is statistically significantly associated with increased lung cancer incidence. So here, NO2 represent surrogate for traffic emissions. NO2 itself may not be a carcinogen, but it represents a broad range of traffic emissions. For example, volatile organic compounds, VOCs. That is a carcinogen. The effect size is about 1%, meaning that each unit increase in each pollutant, the lung cancer incidence increased by 1%. So you might be asking, the effect looks very small, right? So why do we care? Well, because of the very high exposure prevalence, everyone is exposed. That means even a very small risk can be translated into a large number of cases. For example, in that study, each unit increase in each pollutant is associated with thousands of new lung cancer cases in each year within the Medicare cohort. That's why we need large-scale epidemiologic studies to detect those small effects. So far, nothing really new. The link between air pollution and lung cancer incidence is well established. We're actually extending our work beyond lung cancer incidence. We're now looking at the survival of lung cancer patients after diagnosis. This is particularly relevant to healthcare providers as we are focusing directly on patients. So in this cohort study of about 500,000 Medicare enrolled lung cancer patients, as we capture from Senior Medicare, we found that the long-term exposure to PM2.5 is significantly associated with increased mortality after lung cancer diagnosis. And more importantly, we identified the chemical, as we know, PM2.5 is a complex mixture of various chemicals, and we identified the chemicals that contribute more to the overall effect of PM2.5. And in turn, we identified the sources to these chemicals, which include traffic emissions, biomass burning, and industrial combustion. So the point is, we know PM2.5 is harmful, and we need to control it, but how? So by identifying these emission sources, we provide an answer. And again, the PM2.5 is a various mixture of components. The composition of PM2.5 changes over time. One of the increasing contributors is wildfire smoke. Here, the picture shows a smoke day in New York City in 2023. At the national level, the wildfire activity in the US has been increasing over the past decades. And its emissions, in particular the PM2.5, is reversing the long-term decline of national PM2.5 levels since around 2015. So we suspect that the smoke PM2.5 is more toxic than non-smoke PM2.5 because of its higher carbonaceous contents, because of the emission is burning of wood. And those contents have higher potential to cause oxidative stress, DNA damage, epigenetic effects. So we did this cohort study. We used the same cohort from the previous study, the lung cancer cohort. And we found that long-term exposure to smoke PM2.5 has substantially higher risk than non-smoke PM2.5. The effect size for smoke PM2.5 is about 10%. It is pretty concerning. And if we look at the exposure response curve, the smoke PM2.5 has consistently higher risk throughout the exposure range. So the message is that for lung cancer patients, they should be especially cautious during smoke days. But really, this is for general populations as well. We did a similar analysis among the general population, and we got similar findings. So what can health providers do in response? I think, first of all, the patients should stay informed. We can encourage the lung cancer patients to monitor the local air quality and stay aware of the pollution episode or wildfire episodes. When air quality is poor, although the evidence is still relatively limited, some interventions can reduce the exposure level. For example, stay indoors with the ventilation system. If that's not feasible, we should use air purifiers, especially those with HEPA filters, which are now much more affordable. And finally, if you have to go outside, wearing the filtration mask. The surgical mask is not really helpful. And finally, this strategies should be implemented both in home and in hospital. That's all I have for today. Thank you.
We're going to do a panel discussion now. And whose phone is this? So we have quite a bit of time for questions. Are there any in the audience, in the chat? While we get those started, can I ask a question? Okay, so the first question that I have, I want to ask Eileen first, and I actually would like all of the panelists to weigh in. So from a breast cancer survivor's perspective, Eileen, I'm really curious to know what has been your experience talking about environmental chemical exposures and things like that with your providers? And relatedly, how do you think clinicians can do a better job of communicating sort of the things that you may have wanted to know even now throughout your survivorship experience?
Thank you. It's interesting because that doesn't often come up. And if I found myself ever asking that question, I felt like my providers were not educated enough to answer that. And it's not because they're not incredibly intelligent. It's just because that information, and I heard it several times here, it's just not something that is taught. And having worked at a medical school most of my career, and also seeing what the curriculum looks like, it's not there. And so usually I have to rely on another source to be able to get that information. And just over time, because I have an intimate relationship with my care team, the team that saved my life is also the team that I worked with. So I can, plant that seed in their ear. And I think that at least with my care team, that conversation has changed. And some of those studies have started to trickle in a little bit more than and it's not just me, because I think I am part of a trend of people who are asking the same questions over and over again. And so it forces our providers, how much it's changed in the last 17 years from when I was diagnosed and knew very little about this to how much I know. And then as a result, how much even my providers learned because of the amount of questions that we're all asking as survivors. I think it just speaks to how important it is to include that in the curriculum so that people are more educated, and also hopefully one day insurance not meddling so much so that there's more time for consultation so that these more robust conversations can continue to take place.
Thank you. Mary Beth, do you have anything to add about how, you as a clinician talking about these things and how you can do that effectively?
Yes, I think it is definitely first and foremost listening to your patients. I have learned probably as much from my patients as I have from my mentors, and I've found that a lot of women will draw these connections themselves, and they're always sort of looking for a reason. Why did this happen? It's not in my family. I don't understand what's going on, and they'll make suggestions about, do you think it could be something to do with an exposure they had as a child or in the workplace? And I think if you're not open to that and sort of looking into it for them, it sort of serves to sort of shut them out of the conversation. Patients will often lead with what is most on their mind. So I have learned to be a better listener, but then also to be more prepared with the information that they are looking to sort of validate their concerns, and most importantly, direct them to reliable sources of information, because they'll start kind of looking online and they might come across some things that are not particularly accurate or helpful. So having reliable resources to be able to point patients to when they're asking these questions is critical, I think.
So the question for you, Dr. Wei, is I kind of want to tie in your presentation where you mentioned, even though the risk estimates for PM 2.5 and even the components of the mixture appear small, that the exposure is widespread. So how can clinicians, and I would say the public health community, just better communicate risk, to the general public, but also lung cancer patients, as you were discussing?
I think I'm not a physician, but I think I'll be more conservative. I think I don't know if physicians should recommend take those interventions to their patients. For example, during welfare episodes, use your air purifiers, a filtration mask. The filtration mask is a controversial issue. Lung cancer patients have compromised lung function, right? Because there has been, compared to the toxicology and epidemiological studies, the interventional studies, showing that those interventions are effective, can effectively reduce the exposure level, are still relatively limited in terms of amount, scale, and quality. So I'm not, confident that those interventions will reduce exposure level. I think our studies have more important political implications. I think it is a government issue to control the sources, and there's a lot more the government can do. U.S. air quality regulation has really fallen behind if we compare with the WHO air quality guidelines.
Yeah, thank you. Any questions online or in the audience?
Yeah, one question for you, Mary Beth, from online is just to ask you to talk a bit more about how you currently incorporate talking about environmental risk with your high-risk breast cancer patients.
So since my involvement with Silent Spring, it's become a more regular part of my conversation. So once we get through the initial reason for why they're there, let them speak to what their concern. Often it is because of a family member being diagnosed with breast cancer. I actually have inserted it in the sort of modifiable risk factors section as opposed to the social history. So we go through the diet, exercise, alcohol, and I usually start with sort of an open-ended question and just say, do you have any exposures that you think about or that you're concerned about, either from your childhood or in the workplace or where you live currently, just to sort of get the conversation going. Sometimes women will ask me specific questions about that, and if not, then I'll sort of prompt them with some of the lists from the Healthy Homes and talk to them about the Detox Me app and how these things are pretty much everywhere, and it's all risk is sort of cumulative from different sources, and that breast cancer is multifactorial, and so we can take steps to try to control the pieces that we can, and so we talk about the areas where they think there's room for improvement. And then now it's sort of part of my assessment and plan, just right along with, we're going to talk about, doing 25 minutes more of exercise a week. We're going to talk about maybe no more candles or whatever the thing is that they kind of picked out of the list of something that they felt they could do differently. Then I have the benefit of following these patients long term. So I'm able to, the next visit, how's it going? Were you able to do this? And then maybe if they were successful, pick another option on the list for them to work on. And some patients will actually proactively reach out to me through Patient Gateway ahead of the visit to say, oh, guess what? I did this or that. And so it's been a nice sort of additional piece of the conversation. Again, I do try to, these are patients who are generally a little bit anxious. And so I try to let them pick the pieces that they think that they can do well at and succeed at. And that seems to be working for my patients.
I have a question about coming up with ways to educate patients, and if there are any things that systems can do that would be something that would be beneficial. Like if you were a patient, would you go to a class on how to reduce your environmental risk, or is that something that maybe we should have shared appointments for patients, that they should all come and then they would talk about environmental risks? Or is it something that nobody would be interested in, and maybe we should focus on social media or some other way of getting the word out? Like, is there any thought about or any suggestions of sort of out of the box thinking that systems could use to try and come up? And also, what's the right venue? Is this something we should be focusing on primary care providers, or is this something we should be working with our cancer care providers? Because patients also make that transition after they're finished their treatment, and now they're going out into the wild world, and who are they seeing and who's addressing that?
So one of the biggest complaints that we get from patients is the waiting times. And there's always a screen in the waiting room and nobody uses it. It's like to advertise, like, things like this. So that's good too. But I think that those could be opportunities for teaching in multiple languages. And I actually tried to do that when I was in GYN oncology, so that TV could always be on. And since people are waiting endlessly, and then even in the waiting rooms, I always tell people, it's called a waiting room. You know what you're getting into when you go in there, right? But that if we're talking about systems level, I mean, I think, I used to make fun of YouTube University. Now I'm like a proud member of that club. I'm always on YouTube, so I'm always finding out about things. I just start to do deep dives when I'm curious. But not everyone has access to be able to go to things. And I say this as someone who, who ran a program here for a group that primarily doesn't really show up. And I used to have about 65 people a week while going through cancer treatment. So there were a lot of people that were coming. And I think part of it had to do is because they saw themselves in me, and I can speak to them in English and I can talk to them in Spanish, and they were also my neighbors. And so, and when you get one neighbor, you get 20 neighbors. And so, so it has to be really, just more of the theme that I was talking about, more inclusive. But then if we're talking about in a clinical setting, then that's one way. I mean, we have events here all the time, and they're not always well attended, even though the community is filled with people that are dealing with cancer diagnoses. And so there's just, even when we get an iPad, there's so much opportunity there for teaching. My graduate degree is in health education after my diagnosis. So, I always find little ways to creep it in. And so, and then also, like I said before, just having the doctors bring it up. I mean, this is a beautiful program that seems built in, and you're lucky to have it.
I think we can have some kind of early warning system to remind our patients, hey, today air quality is really bad, so take cautious. Yeah, I don't see that. I don't see any message when I experience the smoke days. I know that today is a smoke day because I see it or smell it. So, yeah.
I don't know if somebody from Silent Spring wants to mention this, but they have some novel approaches now working with social media influencers and working with that population to meet people where they're at and where they're getting their information. So I don't know if.
Sure. So I can just briefly share. This is a project that we call the Power Project, and it's working with specifically with Black women who are social media influencers. And what we do is we do some workshops with the influencers themselves to kind of teach them about endocrine disruptors and their sources and their health effects. And then they create content that we review simply for the content for the accuracy, but it's in their voice. And that's what I think is very, very important. As you were just saying, I mean, is like this idea of like, it's in the community's voice, that those are the people who should be the messengers, right? And so it's been really effective, actually. We did a kind of an analysis of looking at what people are learning from these posts about EDCs, and people are demonstrating that they're like learning about what EDCs are, that they're taking steps to reduce their exposure after seeing these posts. So that's really great. I mean, you think about like, that's just, I mean, a couple tens of thousands saw the post, but then it gets shared and it kind of keeps going. And it's like, it's amazing what the potential impact could be by using those kinds of systems like social media.
This is a question primarily for Mary Beth Hans, I believe, but anyone can chime in. I'm wondering if you could talk a little bit about your experience talking to other healthcare professionals about environmental health and if you've been able to change any minds.
Thank you. I have in our program, so I did start with the physicians, the clinicians, by having exposure to the Silent Spring scientists who did a journal club. And as I said, that sort of opened the door. And so now when I speak to different provider groups, GYNs and primary cares predominantly, I do have information there about environmental risk factors, right up there with everything else about diet, exercise, alcohol, smoking. And I bring actually educational materials with me to these talks, and those are the materials that people are most interested in taking, because I think if most people are honest, they are aware that it's something they haven't really learned about formally in their training. And I do think most clinicians are interested in providing complete care and don't like not knowing something. And so then you just give them the opportunity to see where they can find it. But I've actually found everybody to be very receptive. Recently connecting a GYN in our group to Silent Spring because she seemed to have a little interest, and so I just kind of jumped on that. And because I know for me it was hard to know where to get the information until I met the individual who hooked me up with Silent Spring. So it's been well received.
Yeah, another question from online asking about experience talking about lowering risks of toxicity in groups with low-income women, in particular with cancer, and ways to talk to reduce anxiety about what people don't have ability to control.
I think the question has, I mean, it has to come from a place of empowerment. There's already a lot of fear about what we're consuming, you know, the air that we're breathing, because we're all breathing the same air. How did I get this? You know what I mean? And so when we're talking to low-income communities, I like the framing that when you said your talk, it's about, you know, what step can you do? But again, it's not telling someone like, don't drink any coffee out of the plastic lined cup. You're gonna have PFAS in your body forever, and your babies are gonna have it in their babies. So it's like, you know, and that's sometimes how patients used to present into the cancer center. Like, you know, somebody would be sitting in the waiting room and somebody, you shouldn't drink in that cup, you know, and it just became very disempowering. And so, you know, low-income communities have so much knowledge, and it's so much that other cultures pick it up and act as if it's their own. So, you know, so we have those tools, and so it's just about reconnecting back. If you go back far enough to anyone's culture, that's probably closer to how we should be living, even though this is, you know, this world is very fake, the one we live in now. And so it's just about going back. And when you start from going back, then all of a sudden you're just doing something that was natural to you and your people and generations from the past. And if you frame it that way, I think it'll be better received than saying, you're low income and then this is what you're going to do. But the truth is that there are people that are low income and they can't do all the things. Like even when I saw like the filters, I'm like, well, I live in an apartment. I used to live in a house, and when I lived in a house, I bought that, but I can't control what happens in my building. So there's just different things, and I just think it's just about the framing and finding ways to empower.
I have
Yeah,
more.
so the low income community is experience a disproportionately higher risk because first they experience disproportionate higher exposure levels, and second because they are more vulnerable. They experience higher effects from those pollutants. So I really think this is a systematic. It's not we should put more resources, healthcare, education, social support. It's really systematic. That's one of the the EPA scientific advisory committee criticized the current environmental health research in terms of air pollution studies. Not enough has been done to address environmental health disparities.
I have more of a comment. I just wanted to kind of emphasize how, from a clinician standpoint, I think empowering it is to reach patients from the high risk standpoint as well as from the survivor standpoint. Because I think a lot of oncologists, one of the challenges we hear is that you would never want the patients to feel like, if you bring up environmental exposures during like a incidence or cancer diagnosis conversation, you would never want anybody to feel blamed for. And so I think it's a really powerful time during high risk clinic or during survivorship to really talk about these exposures, because it really can empower the patients to make these changes and kind of take control of what they can control. And then, as Dr. Wei highlighted, I think in the environmental epidemiology literature, there is more and more literature suggesting that environmental exposures are impacting cancer morbidity and mortality. So I think those can be really important, impactful places to talk to patients. So kind of tacking onto that, my question is, I was curious, Mary Beth, if you've done any work with like the survivorship population, or Eileen as well, in terms of environmental exposures, because that's one area from my work in the children environmental cancer stuff with PACE I do. That's where we've tried to really put the impact as well in the survivorship clinic.
So I don't work with patients in survivorship specifically, but this is making me think that it's time for me to reach out to my colleagues that do and give them all the resources and maybe just show them how I've structured it in my note and some tips. But I have not done that yet, so I'm glad for the tip.
So in my community, we use Vicks for everything when you have a cold or in your nose. And so I brought somebody that does natural beauty care, and we did in Dominican, because it's not even in Spanish. We call it Viva Puru, which is Vicks. And so I had them do Vida Puru. So Vida is life. And so we connected it to life. And so we made, using essential oils and shea butter and all these different things, we made our own concoction. And then I also remember doing a session where we brought in all what was the stuff that was put on the stove? Fabuloso. Yeah, so that kind of stuff so that we can look at the ingredients. And I don't know, this is going back like to 2010, so I don't know if you guys existed then, but I wish I would have known that then, because we went to certain websites and just looked, and then we created like vinegar-based, like apple cider vinegar. We used filtered water for different things. We just that's when I was at YouTube University, like doing my research, and just figuring out ways to swap out those things that we use on a daily basis for better, just for more safer options and things like that. So, so that's how we're having those conversations, and people swear by things, and so it's hard to change them. But I will say, and this ties into like the low income communities as well, once you get that community fired up, there's like no stopping them. And I think that was really evident just recently, even with the whole election day outcome. And so, once you get a certain community alive and awake, there's no stopping it. And so this is one way to tap into that.
The environmental factor or air pollution affect the survival of cancer patients. There are two pathways. One is through the may promote the progression of tumor. One is through by affecting the severity of comorbidities. So from that perspective, we have some preliminary analysis. Actually, the impact on comorbidities through the comorbidities then lead to mortality it's greater. So from that, based on that, I think perhaps we should have better comorbidity management for cancer patients.
Any more questions online?
Yeah, there's another one. So this person says, in terms of the political change that Dr. Wei talked about, do you feel that environmental folks and healthcare folks are collaborating enough? For example, does the environmental movement have enough information about environmental risk factors for health, and what can be done to improve collaborations and collective power?
I think it's it really depends on what kind of criticize the policymakers have. For example, when EPA deciding whether to lower down the national standard, they criticize first, current studies do not have causal evidence. It's associational. And that means you lack, it's all observational. It's not like experimental. So to address that, we need to collaborate with, economists and statisticians and, various professionals to provide more robust causal evidence. We even do parallel studies using both traditional associational and causal studies to kind of cross-validate each other. And then the criticize that, you have exposure measurement error, and it's not the true exposure, right? To address that, we need to collaborate with, exposure modeling experts, right? So first we improve our exposure model, so it's more accurate. And then we show that, even with that error, the effect the effect still exist. It's overestimate. So without those error, we can get larger effects. So
I think this is where I plug community, and there's so many programs for young children, for high school students, for young college students to partner with some of the researchers that are here, and getting the future voters involved. And then also these people have mothers and grandmothers and dads and family members that have been touched by cancer. And so once you get the kids going, then, organically it just kind of trickles to the rest of the family. And so, just I think funding the research-based program is how you get collective power. And then the louder, now you're touching different generations. And then I think, my congressman's office is a block away from my house, and I know him on a first name basis. So, so once we start getting, and my kids get involved, and so, I think that's the best way to sort of plant the seed, so that if they can work with somebody that's already doing this work, we're already tackling the politicians of the future too, so.
That's it? No more questions online? All right, well, let's give our, oh, sorry, we have one more.
Hi, it's not really a question, but just a thought that I would like to share coming from research perspective. So the take-home message that I feel is that there are a lot of environmental stressors, and talking about avoiding scented candles to tea bags to whatnot. can we develop a program where we develop the allostatic load score, like the environmental stresses, the wear and tear happening, and then impart that knowledge to the normal community as well as the survivorship, so that even though they are diagnosed, they have completed the treatment, they can adopt those healthy lifestyle, because that load score is always happening. We are always going into transition. It's like a very dynamic phase that we're all dealing in, not just cancer survivors, I would say. For everyone, they should have a chronic stressor kind of a metrics to say. Just
So
something to discuss.
I'll just say I love that idea. I study allostatic load, and I think that if we could develop something like that for environmental exposures, that would be powerful, not just for people at high risk, but also for people that are survivors. So all of us in this room, we can think of how to work on something like that together. I think that would be really impactful. Any other thoughts or questions? All right, so I just want to end our session by thanking our speakers and panelists again. All right.
Well, thank you so much. I hope each one of you learned something today. I certainly learned something, and I just want to start by thanking the entire panelists. All day long, the speakers were phenomenal. They volunteered their time to prepare their remarks, and they were just spectacular. So let's thank the speakers. I also want to thank the entire committee that helped plan this. So you are amazing and extraordinary, and this could not have been done without you. So thank you very much, Kim. Thank you, Linda. Thank you, Sarah. Thank you, Emily. Thank you, Emma. Thank you, everybody. Crystal. Thank you, Jesse. Everybody. Near and far. Come right here. My colleague here has volunteered to help wrap up with me. But before we do that, if you wouldn't mind just taking, it should be less than 5 minutes to take this post-test. This helps us with planning the CME for next time. This is the third time that Silent Spring has done a CME, and as you heard today, most medical schools do not have education on environmental health, so it's important to continue these CMEs. And all of the resources that you heard about today, including the specific resources from each discipline, like ACOG, all of that you'll be sent a link to where you can get that information and download the articles that were referred to today, download the slides. Please spread them to your networks. Please use any of the materials that were put together so expertly by our team, so thank you. And please do reach out to us at any time if you have any questions and or would like any people from the panelists today or come give grand rounds or any other kinds of information about what you heard today. So I'll just wait a minute for people to finish that test, and then we have a very brief wrap up. Yeah, just maybe give us a wave. People online, please do also complete this test. We need this for our CME credit. Shouldn't have called it a test, but it's, okay. Okay, great. Okay, okay, great. The slides will be shared. Yes, and the videos will be on the website if you'd like to. I know I'm going to rewatch some of those videos because, yeah, I think every panelist had really great remarks to. Yeah. Okay. Great. All right. Okay. Well, it's fine. People want to get some fresh air fast. All right. Do people have time to do that already, or do you think, Emily? Okay, wonderful. So we're going to, my colleague Sarah and I are going to just pass it back and forth very quickly, but please do chime in too if something you find striking about what we heard today. So we're only going to do the high level review. And so, Sarah, did you hear anything that surprised you today that you didn't know about?
I wasn't prepared for that question. I was prepared for like many other questions.
Okay.
Anything that surprised me today? I mean, I think that my kind of high level overview actually is that while there's a lot of uncertainty and it's really hard to find associations between environmental risk factors and cancers for a number of the reasons that we talked about today, we know a lot. And I think that was kind of like my key takeaway that I hope everyone got as well. We know a lot about exposures that are linked to cancer risk, and we also know a lot about how to reduce those exposures and protect patients and populations.
Wonderful. I actually agree, and I think you hit the nail on the head. That is the biggest message from today. So yes, science is always evolving. There's always more things to test, but we do know a lot. And what we learned today specifically is that there's a very vulnerable window. So in particular, we learned from panel 1 about making sure during that pregnancy window, which we already tell pregnant women to avoid a lot of other exposures, to think a little bit more about reducing risk where you can. Again, not by blaming anyone, but again, by sharing the knowledge that we have. That is really important. We also heard from Dr. McDonald about that postpartum pregnancy window, which is also a window we should be much more aware of and share what we do know and what we don't know. People like when you share information. We've, at Silent Spring, Dr. Julia Brody showed over a number of years that it actually reduces anxiety to share information. So that is a key thing. And then I loved what our clinicians told us about this morning and how we actually can think about that within the clinical visit and how you do that. So thank you so much, Hannah. Yeah, so, and then.
Yeah, and then I wanted to also call attention to Laurel's mistake that I loved about the preventers. And so I kind of came out of this thinking that we should name ourselves the preventers. So we have all of this information, but we kind of identify that it's not necessarily reaching the people that it needs to in a way that is actionable. So I think like our charge now, leaving here, is to go forth and become the preventers. I think we wear capes.
I love that.
Was
I love that. And in order to really kind of solidify that work, again, the emphasis on why research is needed and why specifically we need non-industry funded research to look at the impact of these chemicals.
Yeah, and another theme that really stood out for me all day was the idea of collaboration and team science. And I wanted to share a quote that Karen Miller, who's a breast cancer survivor and the founder of Huntington Breast Cancer Action Coalition on Long Island. She's a long-time partner of ours at Mount Sinai, and she says, if you want to go fast, go alone. If you want to go far, go together. And so I think we heard so much throughout the day about the importance of interdisciplinary and transdisciplinary partnerships, not only between scientists and clinicians, but importantly with patients, survivors, and communities.
Wonderful. And I'll just share with all of you that I learned a great deal about this whole area and communicating specifically about this area, even though I've been doing the research for like 30 years, from one of our community partners about 15 years ago. And Desiree Walker couldn't be here today, but she told me, if you know the information, why can't I know the information? And that was a very powerful thing that I learned, because that's not how my training was. I was trained not to make people anxious, but I didn't know that research is going on, that people trust you more when you share what you can.
Yeah, and I don't know, maybe this is my last thing, but I'm just thinking about the power that we have in the room. And a lot of the things that we talked about today were individual interventions, things that we expect people to maybe be able to go and do in their own home, filter their air, clean, have access to safer cleaning products or consumer products. And sometimes that can be overly burdensome, but I think that we all, because we have this knowledge and power, are the ones that then should be going out to advocate, to promote policy level change so that we can, impact systems level change, kind of like Dr. Way referred to, and I think many others did today as well. So we should take that power forward and keep that in mind as we're advising patients and communities.
Wonderful. And then I'll just leave too with where we started and thank our colleague Linda. Again, averages are okay, but often there's a lot more going on beyond the average. And so the power of prevention, and we are the preventers, is you can see clearly with the decline in cancer rates. But that severe decline has only been in men over 70. And that's primarily driven by smoking going down. So there's huge benefits, and Dr. Bofetta showed us too with hepatitis vaccine. We know from HPV vaccine. And so there's lots of power in that. And so we always can be doing something to reduce our risk along our life course. And I love that we ended with that last panel where, Hannah, you brought up too, the point that we can always be reducing our risk of other chronic diseases. And so even though you may not find out about this kind of information until your first diagnosis, it's still important for your family and for the rest of your life and for the outcomes after cancer. So I think Rob and Dr. Dotson showed us too that these chemicals very much affect our immune system, and we will be studying in the future how these chemicals can affect responsiveness to immunotherapy. That's an important unaddressed gap in our knowledge. You want the last word?
That's all.
That's all? Okay.
I think your last word is good. That's all I have.
Great. So there's more research to be done with all of you, and please do stay in touch. And if you didn't get your question answered online, we will try to, our wonderful Emma recorded everything, and we will try to get back to you, but please do review. The resources will be in your email if you've registered for these. Okay? Great. Thank you.